जी सर।
ठीक है, डन।
विवेक सर, यू आर रेडी विथ योर पीपीटी?
हाँ जी सर।
आर लाइव नाउ।
ठीक। आर वी लाइव?
यस सर।
Good evening, everyone. Welcome to Cerebellum's NEET PG 2025 recall. And with me on the screen are all the legends. We have Dr. Vivek Jain, sir. Sir, good evening.
Hello sir, good evening.
Pur Mehra sir is here, sir. Good evening.
नमस्कार, हाय।
And Spur sir is here, sir. Good evening.
Hi, sir. Good evening.
So before we start the recall, some overview about the paper. We have been discussing with students also and amongst the faculties also. The initial response of many students was it's an easy paper or easy to moderate paper. But after going through the questions and after discussing with the faculty, I would still keep it easy to moderate, but more towards moderate. It was not as easy as it appeared on the first look. There are multiple things that were noteworthy in this paper. PYQs, as always, form the backbone of this paper. There was a good number of PYQs, significant number of PYQs. And if you put PYQ, modified PYQ, and related PYTs together, I think the number might hit somewhere around 155 to 160 question, or even a bit more, 165, if we are a bit liberal with the definition of PYT. Vivek sir, you want to say something?
Yes sir, just one thing. I ran a poll on Telegram group.
Hmm.
67% say it was moderate, 18% say difficult. So we can imagine 85% are saying moderate or difficult.
Right, right. So yeah, so I think despite the questions appearing familiar, the trick that examiners played was some of the questions had very confusing options. So if you look at that question, you might feel, I know this, I have seen it somewhere, but when you have to answer it, you might end up trapping yourself with the wrong answer. So there were fairly good number of such questions. So that is why we are calling it a more towards moderate paper than more towards being easy. As I said, a good number were still PYQs and modified PYQs and related PYTs, but a good number were new questions also. So, uh, I think the segment A, the section 1 was found by multiple students as a bit tougher in comparison. And as it often happens, the last session, by that time, a lot of students gets tired, so it usually becomes difficult by default. So all in all, a balanced paper, I would still call it easier than NEET PG 2024, but not easy in absolute terms. And Spurs sir, when papers like this come in the exam, there is that worry of clustering. Because see, PYQs is something that all of us keep on saying, and every teacher keeps on saying that everybody becomes good at PYQs. So the direct PYQ or very similar PYQ, everybody gets correct. The whole game get decided by those 30, 40 new questions and those 20-25 modified questions where the question appears familiar, but the options have been, changed in such a way that it is no longer an easy question. So those 50-55 questions are going to determine the game. So first
Absolutely.
question to you is that the first response of majority of students was that of relief. It was a good paper, it was an easy paper, but is it safe to say that?
Sir, usually I think I would rather be a bit more conservative because as we have seen in the past, for any kind of a paper which is an all India exam, whether we are talking about the UPSC CMS exam or whether we talk about the NEET PG, a paper which appears easy on the surface is going to be having these two important issues with it. One is that a lot of times it is a recall bias. A thing that is known to us is going to be, recalled easily. I mean, Apur sir ने पढ़ाया था osteosarcoma तो वो आ गया. Praveen sir ने dissociative disorder पढ़ाया. Vivek sir ने बताया था. It's the options which is actually going to be making the things a bit tricky.
Yeah.
Fact number two is that if you're looking at again, as what you find is that these kind of papers usually leave very minimal scope for any kind of a student to make a mistake,
Yeah.
whether it is an alternate topic or whether it is a PYQ question, because again, for that every mark counts usually holds absolutely true for these kind of papers. So, I mean, we have to be very cautious about the way things are going to be turning out to be. And I was having a look at the things that students had shared in the Telegram group as well. I mean, it was almost a kind of a hot heated discussion amongst the students as well. ये point mentioned नहीं था, ये point था. So you can understand with a small tweaking of the questions as well, the answers can change drastically. I mean, we will see it as we run through the course of this particular discussion.
There are, sir, two words that I'm actually worried about. After seeing the paper, actually, I got a bit worried. And my fear is summed up by two words. The first word is the dreaded word clustering. Vivek, sir, do you see a reasonable chance of significant clustering happening in a paper like this?
Sir, it may happen, but like you said, I'll again mention students who have studied comprehensively all the 19 subjects in detail, they are going to shine separately. Clustering will be there. Clustering will be there. But I think, yes, one or two questions will make a big difference this time. It looks like that. PSM surprisingly was last year more easy as compared to this time. This time also it was easy, but this time number of new questions were more.
Yeah. Apur sir, we do not want to go into that game of claiming anything as of today till the picture becomes clear. And I believe that rather than jumping to a conclusion that so many things were covered in that course, at this point of time, it is more important for us to be realistic in front of the students, right? So what is the realistic, I would say, assessment that you have of this paper regarding the number of PYQs asked, regarding the number of new questions asked, and also the difficulty level, sir?
Thank you, Dr. Praveen sir. As I will be sticking to orthopedics as an example, right? There are certain words in long questions that will clinch you towards the diagnosis. In this paper, they were very clearly mentioned. So they had given clinical scenarios, but they had not tried to mix it up. Means if they wanted this to be marked, they were very sure that that word was there in orthopedics. If an image was there was no confusion. Also, in multiple subjects, they had similar type of questions. They had balanced out anatomy with ortho, medicine with ortho. So you have to have an idea of a little bit about both the subjects and concepts. So as we classically used to study etiopathogenesis, then the disease, symptoms, signs, treatment and management, you need to have a grasp of the entire thing to answer. It can be asked anywhere.
Right.
They had shown you a clinical scenario and asked you anatomy. It's reverse. So that is how the paper was. So as you said, the general feeling of everybody coming, I could meet few students, was it's very easy. But as they were speaking to me, I didn't want to disturb anybody, but I realized that they had made mistakes.
Right. Silly mistakes happen in such kind of paper, and we saw it in the INI-CET paper, last INI-CET paper. The general the opinion was that it was a very easy paper. It was like NEET PG. But when the scores came, everybody was shocked. The topper himself got 80% marks, right? And nobody got 170, 175 correct.
Two
So,
things which I noticed, Dr. Praveen, which are there in all our Telegram groups. Number one, that people are saying that FMGE exam was more difficult than this exam. I cannot comment on that really. The second thing, they say that compared to the last year, as you just mentioned, this year paper was relatively easier. I will rate the last year paper 2 and this paper are almost similar. Paper 1 was exceptionally difficult, but paper 2 last year, I'm just talking about orthopedics. So they are more similar here. Let me know when I have to share my screen and start, if there's more discussion to go on.
No,
Sir,
please.
I think we can start. I think Dr. Rana ma'am is here. Rana ma'am, are you there? All right. Of course, you can start now, please.
Thank you. It will just take me a flash. I'll just come. Is it visible? Just for
Absolutely.
confirm. Thank you. So I have been assigned 1 minute per question, and my role here would be to tell you the approach of these questions. Right. First of all, thank you to the students who have given me these questions, and we'll make sure a better quality recording is available for our Cerebellum students in the app ASAP. Right. So here they had given a question: 10-year-old child presents with a painless limb. There was nothing else in this question. And if you have anybody over the second half of the first decade, that is between 4 to 8 years or 4 to 10 years, painless limb, the number one thing that you must think about is Perthes disease. So that is number one thing that you should think about is Perthes disease. So they had shown this X-ray fragmentation of the epiphysis, right? So this was a simple thing. What you had to think about is slipped capital femoral epiphysis was painful. So students are mentioning 10 or 8. It's the same thing. All right. Then DDH is going to be at birth. Some people say TB was there, so it's going to be painful. So the most optimum answer here was Perthes disease. So this was question number 1, image based. And even if this image would not have been there, my answer would not have changed. It will still would have been the same. It would not have changed. Question number 1. As I said, key points were the decision making factors. We have always said that young man, low backache, decreased lumbar movements, reduced chest expansion, heel pain or red eye. So if they talk about heel pain or red eye, young man with back pain, you must think about ankylosing spondylitis. And the diagnostic feature is radiographic sacroiliitis. And according to modified New York criteria, it is unilateral versus bilateral radiographic sacroiliitis on MRI. So answer here was simple, MRI sacroiliac joint. So this goes to INI-CET May, where they have shown the Honda sign on MRI in the same sacroiliac area. So they wanted you to look at the same area. So this is another question which has been classically coming everywhere and they just modified it. The next question is a direct repeat of last year paper 2 of NEET PG. 65-year-old lady, chronic backache with slip of one vertebra over the other, called as spondylo means vertebra, listhesis means slip. People say it was L5S1, L4, L5, so that's okay. But usually this is a classical image that has come, right? So this is very, very important. I have been telling from first 3 things I've been telling. Painless limp in a child, Perthes. I have been telling the students, please do not think further, request. In orthopedics, MRI is the king, right? And spine image is universally asked. Either it's spondylolisthesis or there is slipped intervertebral disc or there is codfish vertebra. That's what they have been asking. The next question was again a clinical scenario where they had told there was a fracture of the tibia. There was severe pain in the leg, which is relentless pain, not relieved on anything. And he had a stretch pain. The moment you have a stretch pain, you think of compartment syndrome. And to further confuse my friends, they had given you that the peripheral pulses were normal. So that's okay. Pulselessness is always a very late sign, the last sign of compartment syndrome. And if you have compartment syndrome, it is a surgical emergency in orthopedics. And the answer is not going to be evaluation or evaluating for something or giving limb elevation or cast or anything else. Number 1 treatment will be doing fasciotomy, releasing up to the deep fascia. So this is again a question that came with a clinical relevance. One question that's universally coming everywhere. It came in FMGE, it came in INI-CET. There's a trauma. There's an interval gap of 48 hours. Patient has got confusion, breathlessness, and petechiae. If you have this is going to be fat embolism syndrome. Similarly, if there's a surgery, an insult, a surgical insult, gap of 48 hours, breathlessness, again similar presentation, you will think of pulmonary embolism. So I said, so these 2 scenarios came this time. And now they asked you in pulmonary embolism, what is the investigation of choice? So CT angiography. I'm sure Dr. Dilip sir will be taking it up, but I just want to tell you, same concept, an injury, an interval gap, and similar presentation of breathlessness and pulmonary embolism and fat embolism. So they had asked you these questions. Anybody of increasing head size, growing head size, old man with warm bones to touch with lytic area. So increasing head size, if they just give you a loan, you will think about acromegaly. But if they talk about increasing head size, old sign with lytic lesion, some people say this question was a very long one where they had shown calcium, phosphate, and very, very high ALP levels. So they are talking about a disease called as Paget's or osteitis deformans. And because it's a high turnover disease, so when you will touch it, there will be warmth because there is more vascularity. All right. So this is going to be paget. So this is something that came. All right. The cotton wool skull, as we say, of increasing head size is actually indicative of increasing head size. And you see it more than 50 years, that is sixth decade onwards. Then you are suspecting an athlete has got injury of the long head of triceps. Now, this is what I was saying. This is Dr. Shrikant going to talk to you about. So they have given you a scenario of long head of triceps avulsion. And now they are asking you where is the origin. So they had given a clinical scenario. You had to pick it up that there was an injury of triceps and where is the origin? So infraglenoid tubercle. This is the question where a student walked to me and said, so you said the opposite forces will call avulsion. Similarly, when I look at orthopedics, linked question, shoulder to ankle. Now they are doing a eversion injury. Inversion means the distal part going medially. So the lateral ligaments are going off. So inversion injury, there is anterior talofibular ligament, the most common ligament injured. But when it's eversion in the, so it's the medial side, the deltoid ligament, which is most commonly injured. All right. And then synovial fluid analysis, rhomboid crystals, positively birefringent is pseudogout because gout is needle crystals and negative birefringence. All right. And meralgia paresthetica nerve root is classical L2, L3, which was asked to the from the student this time. So they were trying to give you the clinical scenarios and you had to pick them up. One of the classical scenario is widening with trivial trauma causing fractures in a child with low calcium levels and high alkaline phosphatase level. And what is it? It's going to be rickets. So this question, the details are yet to come to me. So the answer is going to be vitamin D deficiency, which you have to pick up. So this is, in short, the glimpse of orthopedics, right? And what I want to tell you is that most of the words here which came in the exam, right? They were the keywords, right? And they had to get you the diagnosis. And best wishes to all of you. Praveen sir, if I may just take 10
Yes,
seconds more on
please,
commenting.
please,
There
sir.
is a great appreciation about the recent grand test of cerebellum. A lot of similar questions have come. There's a stress that you should do midnight and PYQ sessions. And if you look at this paper, if people were attempting those PYQs, they are going to be better. And the third thing is clinical scenarios are going to come interlinking the subjects. So there is no shortcut. You need to have grasp of basics of all the subjects. So these are three things which I want to say. And thank you very much for having me here.
Thank you, sir. Vivek sir and Spur sir, can I start?
Yeah, please, sir.
Yes,
Thank you,
sir.
sir. All right, so we had 6 questions from psychiatry, in fact 5 from psychiatry and 1 from forensic medicine / psychiatry interface. The first question was a 30-year-old patient presents to clinic 2 weeks after witnessing sudden death of his father, and we have classical symptoms of flashbacks. There are nightmares and hypervigilance. So the question was straightforward. There's a stressor followed by symptoms suggestive of PTSD, but the catch is the duration of 2 weeks. We know that the symptoms last for more than 4 weeks. We call it PTSD. If it is for less than 4 weeks, it is ASD. So the answer is acute stress disorder. I'm pretty sure that all of you would have gotten this question correct. दिव्यांश is saying मैराथन से डायरेक्टली क्वेश्चन आया. यस दिव्यांश, बट ठीक है, अभी वो बात बाद में करेंगे, अभी कर लेते हैं. सो कंप्लीट. Another very straightforward question. Mr. K is described by his friends as being rigid, overly focused on rules and orders, and a perfectionist. And he often submits his work late because he insists on making it perfect and believes strongly in morality. Which of the following is the most likely personality disorder? So we know that we have talked about this in the classes also, that somebody who is preoccupied with rules, regulations, always looking for perfection, very rigid, does not listen to anybody, is obsessive compulsive personality disorder. And we often joke that it's like the professor or the principal of the medical colleges. So answer is A, OCPD. ठीक है. Also this is a PYQ from yesteryears. बहुत पुराना PYQ है, उसी को I think modify कर दिया है. A 35-year-old man is found wandering in another city by a social worker. He appears confused about his identity and cannot recall how he reached there. There are no signs of intoxication and medical evaluation is normal. He is unable to provide any personal information and appears to have traveled suddenly and unexpectedly from their home. There are two options, dissociative amnesia and dissociative fugue. And why am I saying is somebody has picked this question from long back is now dissociative fugue is a part of dissociative amnesia according to the new guidelines. But they have given it as two different options. And the answer is dissociative fugue. If you remember in the class also, mission class also, I said the exact same thing that although they are now a part, fugue is a part of amnesia, but still remember it as a separate entity because they may ask it in the exam. And that's exactly what they did. So I hope dissociative identity was in the options. ठीक है, इसको ठीक कर लेते हैं. Dissociative identity. ठीक है. All right. Memory was an option. Yes बेटा. Dissociative memory amnesia भी हो गया. अच्छा 100 kilometers लिखा हुआ था. ठीक है. This I will add in the final version of the question. In the PTSD order, dissociative identity. ठीक है dissociative identity कर लेते हैं, कोई बात नहीं. Answer remains the same. Earthquake था उसमें. चलो ठीक है. Anyways, in which question there was earthquake? Anyways, a young man presents with a psychiatry OPD reporting that when he sits down, he hears birds flapping their wings. He believes it is a sign from God directing him to move in a specific direction. Which of the psychopathology, following psychopathology does it represent? Now, this is a slightly tougher question, although it is again a part of your SFRS, which everybody studies. But basically what here is happening is there is a perception. The perception is that patient is hearing birds flapping, and to that he is adding a delusion that God is giving me a specific direction. So remember in the class we said that if there is a normal perception and a delusion is attached to it, it becomes delusional perception. Remember my example, the color of this pencil is white, it means I am the richest man on the earth. Perception followed by delusion makes it delusional perception. Delusional memory was there in the options. ठीक है. Delusional memory and visual hallucination. अच्छा. Does he hear the birds flapping or is he seeing the birds flapping? Hear है या see है? Hear था or was it seeing? Visual or auditory? Visual. He was seeing the birds flapping. ठीक है. ठीक है. Anyways, it does not change the answer. There is a perception followed by delusion, which makes it delusional perception. देखो तुम लोग हियर बोल रहे हो, सी बोल रहे हो, कोई बोल रहा है हियर एंड सी. वेरी गुड, बहुत बढ़िया. चलो. Lastly, this I hope all of you got it right. And Spurs sir, this is something that I'm covering in psychiatry. Spurs sir ने मुझे म्यूट पे डाल दिया है. और schizophrenia.
कर दो सर, कोई बात नहीं. I'll take care of it this as well. Don't worry.
On haloperidol was responding well for last 2 years. So you remember this? I talked about this. If they say that a patient with schizophrenia is on treatment for long years, many years, or for many months, immediately the thing that should come in your mind is tardive dyskinesia. So 2 year का treatment है. He is presenting with dyskinesia, some coriform movements and dystonia. So this goes in the favor of tardive dyskinesia. And tardive dyskinesia treatment is VMAT2 inhibitor like valbenazine. ठीक है. All right. So these were the 5 questions. I hope you got all of them correct. And there was another question that a patient is hearing some voices and he commits a crime. What will you do next? Atul sir would be covering it, right? So that's it from my side. Over to sirs.
Yeah, sir, I'll take it, sir.
Thank you. Stop sharing.
Yeah, so hi guys, I think the screen is pretty much visible, and I think most of the questions from the subject of pathology were fairly crackable. Pretty surprised to see that about 3 or 4 questions were almost similar to the ones that we talked about for the FMG exam as well. So let's get started with a discussion on the questions. The first one that they made a mention was a patient who was having a presentation in the form of a spontaneous bleeding, and he underwent several investigations. And it had the mention of the fact the patient was having the presence of blast cells, having a percentage more than 25%. And there was a very clear-cut image which was having the presence of the blast cells and was having the presence of ear rods. Right. So obviously, when you are having the presence of an acute presentation and you're having the presence of ear rods, that would obviously be associated with the patient who's going to be suffering from a condition like AML, right? And the clinical presentation of a patient having a spontaneous bleed would go in favor of maybe a picture like DIC. At any point of time, if I'm talking about the presence of AML and DIC, the first thing that would come to my mind is going to be acute promyelocytic leukemia, or I'm going to be thinking in terms of the translocation 15-17. So I think that was fairly easy question that they had given you in the exam. So nobody had a doubt regarding this particular question. Of course, in our group as well as separately, people were making a mention of the fact separately, sir, कि NPM mutation का कुछ दिया हुआ था option. Just for the sake of a reference for a future question, we had a discussion about the new classification of AML as per the WHO, wherein the first category of AML is the one in which you are having specific genetic translocations. You just need to remember it for two specific reasons. Reason number one, guys, that this is an example of a condition in which the patients typically are going to be having better prognosis. If you have a presence of a specific genetic aberration, it is usually associated with a better prognosis in the patient. Fact number two, if there is a presence of a genetic mutation, you would not be following the criteria, that is the presence of a cutoff value of 20% of blast cells. Right? From that perspective, this becomes obviously a very important thing. Of course, the other options were fairly easy. That is what you just need to remember over here. Okay, it was translocation 821 was there. Okay, guys, I will just make a mention of this one as well. Right? The most common, most likely और most common में तो similar चीज होगी ना यार, तो translocation 15-17 होगा PML वाला, right? So that should not be very difficult. 62-year-old था, तो age भी match कर रहा है आपके patient का. Most likely भी आप इसमें mention कर देते हो, so that you are going to be having a good time over there, right? The next one was about investigation of a patient who was having the presence of certain tumor cells in which CD markers were mentioned over here. Now, this was not the question in which he is asking about to make a diagnosis. I mean, CD5, CD23 positivity, all of you are aware as a feature of CLL, smudge cells, blah, blah. But the question was ultimately about how do we detect the presence of CD molecules in case of a patient having a cancer or a tumor. So when we are talking about detection of CD molecules, of course, the best investigation that would be going in for flow cytometry. Something that we have talked about in the mission class, something that we talked about in the quick revision video. And I think this is one of the topics where I always told you, Vivek sir will show you the graph, the histogram dot pattern, and I'm going to be telling you about the flow cytometry stuff. So detection of CD molecules is what was asked you as a question over here, right? So that was not difficult at all. अच्छा, cytogenetics add कर देते हैं भाई. Cytogenetics में यार अगर subsequent exam में people who are watching this particular, let's say, video for any subsequent exam, they can tomorrow ask you a question pertaining to something like fish, right? So that is the only thing that I would just be adding top of the information over here. Of course, please don't worry about all the choices being given absolutely specifically. This is the best that we could recall with the available time. You would be having a far better discussion and a complete discussion as in when we are going to be having it in the app, right? The next one did make a mention of, now this was having, some people had a long history, but ultimately people were happy to see that there was presence of CA125 elevation. Majority had an idea that this is an example of a tumor marker associated with ovarian tumor. The only catch point in the question perhaps was that this is a marker for tumors which are going to be classified into the category of surface epithelial ovarian tumors. Right. So whenever I'm going to be making a mention of the fact, karyotyping bhi add kar dete hain bhai. So whenever I'm going to be making a mention of the fact that there is going to be presence of elevated levels of CA125, I would go in for a tumor which is going to be arising from the surface epithelium. So I can obviously rule out the presence of something like granulosa cell tumor. वो तो आपके exams में multiple times पूछा ही है when they are talking about col-Exner bodies and stuff. Teratoma and disseminoma can also be ruled out. The only example that was perhaps given over here was serous cyst adenoma or serous cyst adenocarcinoma. Some people had a discussion about the fact that I think mucinous tumor was also mentioned. Right, but talking about the fact that if I'm going to be talking about the appearance of a cavity in which the tumor has a tendency to be bilateral, I would rather go in for something like serous cyst adenosarcoma. Okay. So I'll be looking at your chat box. Don't worry, guys. I mean, that would just help us in refining of the questions. I reiterate the fact that this may not be the perfect thing, but over here, but then of course, yeah, this is not the time where I can actually guide you. Aapke 180 आए हैं, 196 आए हैं, what is going to be your rank? But I'm very happy that if you are actually getting that kind of a number for you, right? The next question that made a mention of a patient who was around 30 to 32 years old, and he was having the presence of a testicular mass which was gradually increasing in size, and it had the presence of a testicular biopsy where you could just make out the presence of cells which are having the presence of a clear or empty appearance. We had a discussion about this as a previous NEET PG question in which you are having glycogen which is present inside the tumor cells, which typically gets washed off, thereby giving you the presence of an empty appearance, or what is given the name of the glassy or the watery cytoplasm. You are having the presence of clear defined septa over here. There is a presence of lymphocytic infiltration. Age of the patient, testicular mass, clear looking cells, glassy or watery cytoplasm, lymphocytic infiltration. I don't think would you have been having doubt on this. This is going to be a case of a patient suffering from a testicular seminoma, right? The next one that we are talking about is a female who was having a presentation. She was having the presence of dry eyes and dry mouth, and she was also having presence of certain autoantibodies. Again, whether it was anti-Ro and La both mentioned, but the point was that eventually he wanted you to make a diagnosis of this is going to be Sjogren syndrome. When I'm dealing with a patient suffering from Sjogren syndrome, autoantibodies just help me in giving a hint, but ultimately the diagnosis is going to be done on the basis of the lip biopsy. And what is the typical finding that I'm going to be seeing on the lip biopsy? This is an autoimmune disorder characterized by lymphocytic cells causing a damage and infiltration in the ducts and the glands. So that is what we just wanted us to have an option over here. Embryonal tumor. Thank you so much for that add-on. Embryonal tumor. Okay. Okay, both were mentioned. So that is again, I mean, this would have made you pretty happy, no? So embryonal tumor कर दिया भाई उसमें, right? So eosinophilic infiltration and neutrophilic तो नहीं होगा. I mean, that is what is known to you. The next one that we are talking about is a patient who was having the presence of a lymph node enlargement, which on examination had tumor cells, which were having CD10 positivity and BCL2 positivity. So if I'm thinking in terms of a tumor, which is going to be a lymphoma, because it is having the origin from a lymph node enlargement as a presentation and having the presence of CD10 cells, so and having a BCL2 overexpression, I would be rather thinking in terms of a tumor like follicular lymphoma. Whenever I'm talking about follicular lymphoma, this is what is going to be associated with the fact the patients are going to be having the presence of a translocation, which is going to be translocation 1418, right? The other translocations are what are already known to you, but this particular translocation is what is going to be associated over here. इसी क्वेश्चन में recurrent oral ulcer, you sure? लास्ट क्वेश्चन में recurrent oral ulcer, okay. ठीक है, वो जो हमने क्लिनिकल प्रेजेंटेशन डिस्कस किया, अगर आपने वीडियो देखा है, सो उसके अंदर हमने डिस्कशन किया ना कि द पेशेंट्स कैन बी हैविंग द डेवलपमेंट ऑफ डिस्फेजिया, दे कैन बी हैविंग अ ग्रिटी सेंसेशन, दे कैन बी हैविंग हैलिटोसिस, ऑल दोस थिंग्स आर गोइंग टू बी सीन एज मैनिफेस्टेशन. सो यस, रिकरेंट ओरल अल्सर्स, क्लीव्ड सेल्स लिखा होता है इसके अंदर, सेंट्रोसाइट सेंट्रोब्लास्ट का मेंशन था. आई मीन दैट वुड हैव बीन मेकिंग द थिंग्स इजी. Oh, thank you so much for those kind words. The ultimate aim is that you were able to crack the questions. I think our job is done. I mean, irrespective of whether all the things were given. Options were different. मेरे को बता देना यार chat box के अंदर. We'll just take care of that. Don't worry. We are then making a mention of the fact. I mean, this is a question in which the patient was having the presence of the classical jaundice, anemia, and splenomegaly. This triad itself signifies that the patient is having the presence of a hemolytic anemia, and typically the patients are going to be having extravascular hemolysis taking place over here. Now, this patient was also having the presence of a positive family history. So obviously, if I'm talking about a positive family history and I'm talking about jaundice, anemia, splenomegaly, with a mention of increased MCHC, I would obviously be thinking in terms of a patient who's going to be having the presence of hereditary serocytosis. So we had a discussion so many times earlier differentiating this condition from autoimmune hemolytic anemia. In autoimmune hemolytic anemia, you would not be having the presence of a positive family history, and Coombs test turns out to be positive. Why is it not going to be thalassemia? Anemia, jaundice, splenomegaly can also be seen in thalassemia, but thalassemia would also be having hepatomegaly as an additional manifestation. In case of thalassemia, you will not be having the presence of increased MCHC, guys. Just remember that. So increased MCHC itself is a big hint along with the positive family history and the mentioned features over here that patients are going to be having the presence of hereditary serocytosis, right? If I'm talking about the next one, this was perhaps one of the easiest questions in which they just wanted you to have an idea pertaining to the role of caspases. So if I'm talking about necroptosis is programmed cell death without caspases, so that cannot be the answer over here. Ferroptosis is iron-dependent programmed cell death. Again, a question on which had been asked in the exam earlier. This cannot be the answer. Therefore, the combination that is most suitable having the involvement of caspases is apoptosis and pyroptosis. Needless to say, the roles played by caspase 1, 4, 5, 11, and then we're talking about 3, 6, 7, right? That is what is to be remembered over here. Next question, make the mention of a patient who was having features where he was a tall guy. He was having the presence of a lens subluxation because of which he was having an issue. And this is likely to be fitting in a diagnosis of a patient suffering from Marfan syndrome. Last year's question, if you know, similar question which was asked in the FMG exam, about which we had a discussion as well. So this is a patient who's going to be suffering from Marfan syndrome. And the moment I'm thinking in terms of a patient having Marfan syndrome, of course, I know the fact that this condition is going to be caused because of a defect at the level of the fibrillin 1 protein or the FBN gene present on chromosome 15. That's known to us, right? Hanji, isme add kar dena yaar if there is anything that you wish to have. Then we are making a mention of maternal inheritance. So straightforward question in which you just need to have the word, the mitochondrial inheritance and the word mentioned, or maternal inheritance. I mean, ruling out the other options also would have been easy. And Duchenne's muscular dystrophy is going to be an example of an X-linked recessive condition. That has been as a separate question. Osteogenesis imperfecta is an autosomal dominant condition. Remember the blue sclera, brittle bone stuff that we had made a mention. Prader-Willi is going to be exemplifying the example of a condition in which you are having genomic imprinting. So by exclusion also, I mean, you were already aware of the answer as the Kane-Sayre syndrome. The other one that we have made a mention of in our discussions in the mission classes was the presence of the Mela syndrome, about which they asked you a question, and Leber's disease, right? So fairly easy, I again would believe. Isme pedigree chart tha, okay. I can just perhaps add it over here. Pedigree chart was there. So ultimately in the pedigree chart, you would have decoded that there was a transmission from the mother to her progeny, but the disease is not being transmitted from the father to the next generation, right? Williams syndrome था एक ऑप्शन के अंदर, ठीक है जी. विलियम सिंड्रोम ऑप्शन में था एफएमजी के एग्जाम के अंदर भी, हाइपर कैल्शियम ऑफ इन्फेंसी वाले में भी. सो देयर वाज एन ऑप्शन कॉल्ड एज कॉल 5. ठीक है जी, सी की जगह पे. अच्छा ठीक है, थैंक यू फॉर दैट करेक्शन. राइट, ए कॉन्ड्रोप्लेजिया था इंस्टेड ऑफ ड्यूशनीज. इज दैट व्हाट यू आर टॉकिंग अबाउट? अच्छा, ए कॉन्ड्रोप्लेजिया में तो आपको पता ही है स्टैंडर्ड फीचर्स. आई मीन विलियम्स था, ए कॉन्ड्रोप्लेजिया था, ठीक है, फेयर है. The next one that we make a mention of is a patient. This is a question already taken care of by Apoor sir, but this was similar question asked to the one in the FMG exam as well, in which the patients were having the presence of a fractured femur, after which he has a development of a dyspnea, rash, and anemia. And this patient is now going to be having the presence of, right, the fat embolism. That is what is known to us. Of course, an image-based question had been asked earlier, in which we are having the presence of empty-looking vacuoles in the pulmonary tissue, which is going to be seen in these patients. Male, females equally affected. Okay. Males is equal to females. All generations affected. Thank you for that input. Okay. Rash on the chest. ठीक है यार, वो chest पे हो जाएगा, trunk पे हो जाएगा basically rash, and all of you are familiar with the GERD criteria that we are talking about, no? CNS manifestations, anemia, thrombocytopenia, and the patient's having a development of dyspnea. Right? Then we are talking about a patient who was having the presence of an abnormal gait, and he was having hearing issues as well. He undergoes the biopsy of the suspicious mass, which had the presence of antennae A and antennae B areas. The moment you think in terms of antennae A and antennae B areas, of course, the first thing that would strike your mind is going to be schwannoma. Of course, we are talking about a patient who's going to be suffering from a condition like acoustic neuroma, with the mention of the term over here. Right? So this was a fairly easy one. Making the mention of the next one, the child who was having the presence of a visual defect and headache had a presence of a supracellular mass. I mean, whether headache was mentioned or not, just let me know about this particular thing. He was having the presence of a wet keratin as a finding. This was one of the questions that we had in the GTs, if you remember, in which a patient is going to be having a supracellular mass in a child. One of the things that you would be thinking over here is going to be the presence of craniopharyngioma. Now that goes very well with the presence of wet keratin as a finding in this patient. Right? So if I'm talking about a patient who's going to be having a supracellular mass, this could be a pituitary tumor, like a pituitary adenoma. But when I'm thinking in terms of, remember, C for craniopharyngioma, C for child having the presence of a supracellular mass, and he's having the presence of a wet keratin, this is more likely to be going in favor of something like a craniopharyngioma. अच्छा, उसमें था at cerebellar pontine angle. Okay. Okay. Thank you again for that. Rathke's cyst was one of the options. Okay. But Rathke's cyst के अंदर wet keratin तो नहीं होता ना भाई. इसमें आपको एक पॉइंट बताया था मैंने, अगर क्वेश्चंस आपने किए जीटी के अंदर, सो वी हैड अ डिस्कशन अबाउट दैट मोटर ऑयल लाइक फ्लूइड व्हिच इज प्रेजेंट इन दीस पेशेंट्स ना, इफ यू रिमेंबर अबाउट द वेट केराटिन एंड दिस स्टफ, वेयर वी डिड टॉक अबाउट समथिंग लाइक सिस्टिक. शॉर्ट स्टिचर वाज आल्सो देयर. ओके, short stature was mentioned in the stem of the question. So he had basically visual defects and short stature. Is that what was mentioned? Headache was there. Okay, ठीक है, fairly. Optic neuritis was one of the options. So you're practically converting this from a path question to an ophthal question. That is what I understand in summary. Nonetheless, 50-year-old female who had jaundice and pruritus with presence of anti-mitochondrial antibodies. What is the likely diagnosis? Remember the story that we talked about in case of Amma over there. So whenever I'm talking about anti-mitochondrial antibody, 50-year-old female, of course, I would be thinking in terms of a patient who's going to be having primary biliary cirrhosis or primary biliary cholangitis. Right? The other options obviously can be easily ruled out. The antibody, of course, that you're aware, which is going to be seen in a patient suffering from sclerosing cholangitis, happens to be P-ANCA. Then making a mention of the fact the patient was having the presence of a thyroid tumor, which has having the expression of chromogranin and synaptophysin. Now, whenever you're going to be having chromogranin and synaptophysin, this is suggestive of a neuroendocrine origin. And the only example of a thyroid tumor that should be striking your mind over here is going to be medullary thyroid cancer. So no doubt about that particular thing. This is quite similar to the ones that we have talked about earlier for two reasons. In case you recall, chromogranin synaptophysin positivity would have been a feature of a lung neuroendocrine tumor, which was the oat cell carcinoma or the small cell cancer. And then we made a mention of chromogranin synaptophysin are the older markers, where we did talk about the neuroendocrine tumor and the newer marker, which was asked as an INI question, INSM1. So for this particular question, I think the TTF also given as an option. Okay. So they made it fairly easy for you. I mean, no doubt about that. Undifferentiated. Anaplastic को undifferentiated बोलते हैं ना भाई? Okay. Amyloid was also there. फिर तो अब if amyloid was also फिर तो छोड़ा क्या उसने आपके लिए यार? फिर तो नीट पीजी का क्वेश्चन का ये तो स्क्रीनिंग एग्जाम का या यूजी का क्वेश्चन बना दिया. Anyways, I mean, easier the better. When we are talking about this question, this was the only question for which I could not get the complete stem. Maybe might be discussed with you by in medicine as well by Dilip sir. The female was having the presence of a skin thickening, and she was having the presence of SCL70 positive antibody. So this is pretty much suggestive of the fact that we are talking about the presence of what is given the name of systemic sclerosis. Systemic sclerosis is what I'm talking about over here. So one of the initial manifestations of systemic sclerosis is going to be Raynaud's phenomena. We had a discussion that whenever we talk about Raynaud's phenomena, white followed by blue followed by red, but we also made a mention of the fact that this is one of the earliest manifestations of a patient suffering from systemic sclerosis. ILD was one of the options. Okay. Myocyte was one of the options. So guys, Raynaud's phenomena is going to be the early manifestation, and that is what you just need to have an idea. Calcinosis cutis. Okay. Calcinosis. ठीक है. इसने early mention किया था question के अंदर. I mean, this is just for the sake of our discussion. I mean, a lot of these can be actually present in a patient having systemic sclerosis. Pulmonary involvement can be having ILD, but if we made a mention of early manifestation, then that perhaps made more sense because that was a previous question as well. Most specific was what was asked the question. Okay. इसमें amyloid नहीं था ये. Most specific manifestation. Okay. Thank you for that input. We'll just going to be having a look at the options again, and perhaps I'll let you know. Right. We are talking about the next question then. Now, this was a question which was recalled by a lot of people. Factor 9 deficiency gets better after giving vitamin K in which of the following conditions? Now, this was not a difficult question at all. You see, vitamin K is an example of a fat-soluble vitamin, right? So if my patient is going to be having vitamin K deficiency, which of these conditions is going to be having vitamin K deficiencies? Vitamin K deficiency, of course, is going to be responsible for causing a lowering down of the levels of factors 2, 7, 9, and 10. Of course, that would translate into the fact that my patient is going to be having a higher chance of bleeding as well. So if my patient is going to be having a factor 9 deficiency, which gets better after vitamin K, I have to think in terms of vitamin K being a fat soluble vitamin not being absorbed in which of these conditions. Pernicious anemia is going to be ruled out automatically. That's a B12 problem because of autoantibodies and the T cell mediated damage. When I'm talking about classic hemophilia is Royal's disease, that is hemophilia A. So no role of factor 9. Factor 9 is going to be hemophilia B, right? Or Christmas disease, as we understand. Hepatitis is not going to be associated with development or deficiency of vitamin K per se. But yes, bile duct obstruction is one condition which can definitely be responsible for causing less quantity of bile available in the GI tract, as a result of which the proper absorption of the fat soluble substances is not going to be taking place, and that would be including vitamin K as well. So I think this is what you just need to have an idea over here. I mean, bile duct obstruction is what is fitting in the picture. Our indirect question, that is the only question that you just needed to have an idea over here. Childhood दिया हुआ था. Okay. I'll be looking at your chat again. Don't worry. So every one of you is giving an input. Please, it is not going to be wasted. Thank you so much for that. Hemophilia A नहीं दिया हुआ था, classical दिया हुआ था. ये तो people had a query separately as well. Then we got a question in the exam which was about a patient who was having recurrent meningococcal infection. Now, two questions which were given in the exam. One was a path question immunology in which a patient was having recurrent meningococcal infection and the complement protein deficiency was what was asked in the exam. And therefore, this was a patient who was having a problem at the level of the late complement proteins. So except for C9, we understand the fact 5, 6, 7, 8, they can be responsible for causing development of the gram-negative diplococcal infections. That means Neisseria meningitis and Neisseria gonorrhea infections are going to be more commonly seen in these patients. Right? So that is what you need to remember. Classical to hemophilia A hota hai bhai. Classical is hemophilia A, right? The next one that we talk about is a patient. This was actually borrowed from Derma because of the fact that it was given as a question. I mean, similar to what we talked about, patient is having gluten sensitivity. He had a development of skin lesions and the immunofluorescence pattern was given. I think they also made a mention of the Ig antibody being present at the dermoepidermal junction. Remember, this is what we talked about in the mission class. Ig antibody present at the dermoepidermal junction, giving a string of pearl appearance. Not to be confused with string of pearl. I mean, that is what we talked about in case of patients who are having an ovarian issue as well. String of pearl appearance, dermoepidermal junction, Ig antibody can be nothing else but a patient is going to be having dermatitis herpetiformis. Dermatitis herpetiformis. C3 C5 नहीं था तो कुछ और बता दो भाई. IgA mentioned था ना, so IgA तो इसमें हो गई ना abnormal antibody because of gluten sensitivity, right? So we talked about two complications ना. One is a dermatological complication which is dermatitis herpetiformis. The second is a bowel complication, long-term complication that is enteropathic T-cell lymphoma. IgA deficiency in these patients. IgA deficiency में कैसे काम करेगा यार? Rash on the elbow was also mentioned. Okay, skin lesion, rash on elbow. Okay. Pemphigus was also given as an option. Pemphigus vulgaris, your couple of exams back question. Thank you. Skid का question इसमें तो नहीं आया था यार. Skid question came in the FMG exam, no? वो INI के अंदर आया था इसमें. Then you got a image which was quite similar to this one. I mean, there was a tussle between the students pertaining to the exact image which was given in the exam. But I presume an image which was similar to this, in which you had a discoloration on top of it. The image was showing you the finger which was actually swollen. And that was very much suggestive of some kind of a secondary infection taking place over here. Had it been a case of Raynaud's phenomena, you are just going to be having a vasospasm responsible for the color change, not the swelling and not the kind of a feeling of that there is a secondary infection or a pus-like material or some kind of a trouble over here. But this kind of an image is more suggestive of a secondary infection. So therefore, this is going to be more going in favor of a condition like wet gangrene in the patient. Okay, elbow and buttock. Okay. Tenosynovitis. Okay. Okay, thank you. Then we are making a mention of the fact that which of the following is an example of a condition in which the patients are going to be having the presence of hemosiderin-laden macrophages in the pulmonary tissue. So hemosiderin-laden macrophages are what are also being given the name of heart failure cells. Classically, that is going to be seen in a patient suffering from left ventricular failure because of the presence of high pressure responsible for causing leakage of the blood over here, and the RBCs are going to be taken up by the macrophages. Some people were of the opinion that the question was an accept question. Dry कैसे हो जाएगा भाई? ड्राई कैसे हो जाएगा? सिर्फ डिस्कलरेशन थोड़ी देखोगे, स्वेलिंग दिख रही है आपको, इतनी अच्छी खासी आपको उसके अंदर दिख रहा है दैट देयर इज अ प्रेजेंस ऑफ अ necrotic material also which is likely to be seen over there. So okay, this had except. What are the other options which were given? I mean, left-sided cardiac failure was definitely one option. Volume overload was one of the options. Pink frothy sputum also. So that is very much suggestive of a back pressure change. Pink frothy sputum being present, back pressure change. आरवीएफ ऑप्शन में था, एलवीएफ नहीं था ऑप्शन के अंदर. आरवीएफ के अंदर hemocytin laden macrophages. Wow. अच्छा, एक्सेप्ट था. सो आरवीएफ के अंदर हीमोसाइटिन लाden macrophages कैसे ले आओगे यार? कंजेस्टिव आप चेंजेस लेके आ सकते हो, बट देन यू आर गोइंग टू बी हैविंग दोस leakage taking place in the spleen and in the liver, not in the pulmonary circulation. ठीक है, ऑप्शन बता दीजिएगा यार प्लीज. पल्मोनरी एम्बोलिज्म. Okay, pulmonary embolism can be having an association with the hemorrhage as well. But we'll just have to look at the other options as is going to be talked by you. JVP raised. Pulmonary vein obstruction. So I think there is a different set of people who are watching this particular live with the respect to the students who gave us those questions on in the Telegram group. I would rather be happy if you can just join the Telegram group and let us know over there. This was, I think, an anatomy question in which they made a mention of something like a transitional epithelium. And of course, you just wanted to have an idea about where exactly is the transitional epithelium or the urothelium find. So it is going to be seen in the urinary bladder. It can be seen in the ureter as well. That is what they just wanted you to have an idea. JVP raised. JVP raised. Okay. राइट ही था पक्का. ठीक है जी, एक्सेप्ट लिख लिया भाई मैंने. Okay, so those were the questions which were asked from the subject of pathology, in total about 20-21 questions, I think. You'd be surprised that this time around I am also going to be having some kind of a discussion with you from the subject of pharmacology as well, because Gobind sir is not available. Pretty much important questions asked in the exam, but then we can just be having a look at this one as well. This first question was making a mention of a patient who was having the presence of a migraine. So this lady was having a history of development of migraine, and she was started on sumatriptan. She had no comorbidities, but she had a positive family history of coronary artery disease. You remember a previous INI question in which the patients who are going to be having the development of a coronary artery disease are going to be taking care of their migraine by giving a drug which is given the name of butorphanol. This question is making a mention of the fact that she is having the presence of migraine. She is not going to be having the presence of, she's having no comorbidities, but she's having a positive family history of coronary artery disease. Now, the question was asking you about the migraine prophylaxis drug. So obviously, if she's going to be having a problem with respect to sumatriptan, I would not be giving a drug like naratriptan in this patient. And for prophylaxis, the best drug that is going to be given is going to be a beta blocker. Non-selective beta blockers are going to be given so far as the prophylaxis of this patient is going to be concerned. You see, other drugs which are going to be mentioned over here, flunarizine as well as topiramate, are going to be useful, but they are not as effective as propranolol. So you have to choose the best drug over here for prophylaxis, and therefore the best answer over here is going to be propranolol. The next one that we talk about over here is going to be 36-year-old woman who was having the presence of severe eosinophilic asthma. She continues to have frequent exacerbations which are controlled by ICS as well as long-acting beta agonists. Her blood eosinophil count was significantly elevated, and she was started on a drug which is benralizumab. Benralizumab was a new drug that you need to have an idea. It's an example of a drug which is specifically going to be active against interleukin 5. You may be having an idea about this particular drug. What I want you to remember over here is that benralizumab has got two important indications. One is the patients who are going to be having severe asthma. I mean, please remember that from the perspective of a future question. Patients who are going to be having severe asthma. And the second condition for which this particular drug is indicated is EGPA. EGPA is the same condition that we read about in small vascular disorders, which is also known by the other important name of Churg-Strauss syndrome. राइट तो ये वाली चीज आपको ध्यान रखनी है ईजीपी और सिवियर एस्थमा के लिए यू आर हैविंग अ मोनोक्लोनल एंटीबॉडी अगेंस्ट इंटरल्यूकिन 5 व्हिच इज गिवन द नेम ऑफ benralizumab. The next one that we talk about over here, TNF alpha था एक ऑप्शन के अंदर, I will just add it over here. ठीक है भाई. The next one that we talk about is a 60-year-old boy who was brought to the emergency department with a generalized tonic-clonic seizure. He had a fever of 102 for the past few hours, and this was his first seizure episode. He's not on any medications and has no past history of seizures or neurological illness. What is the most appropriate treatment? Now, this guy is already having the presence of a high fever, and he's already thrown one particular episode of seizure. So the first aim of your treatment is going to be controlling his seizure, and that is going to be best done with the help of a drug like diazepam. Had it been a situation, मैं question को थोड़ा सा modify करता हूँ. Had it been a situation where he is not throwing any fit, he has not had any seizure, and he's just having high fever, then would have perhaps sponging and paracetamol would have helped. I mean, you would not be given anti-epileptic drug just for the sake of prophylaxis. But since he has had an first episode of seizure, therefore you have to give a drug like diazepam for the management of his seizure over here. Right? So that is what you just need to remember. Ethosuximide था एक option के अंदर. Okay. But GTCS है ना यार, ethosuximide क्यों दोगे? वो तो that is something that is going to be given for, as you are aware, absence seizure, no? GTCS है ना भाई, वो भी तो ध्यान रखना है. Then this was a classical presentation of a patient who was having the presence of insulin-dependent diabetes mellitus, and the complication that was mentioned in the patient was having the presence of an altered sensorium because of the fact that she missed her insulin dose. So looking at the values, what you can pretty much make out over here is, just to put it in a summary, that we are dealing with a patient who has entered into a critical phase of diabetic ketoacidosis. Any patient who's going to be entering in with diabetic ketoacidosis in your emergency, you would like to give this patient a lot of fluids. That is going to be typically normal saline. This patient obviously has to be given insulin. And as you are aware, you are going to be monitoring the potassium levels of this patient as well. Right? So it is the potassium insulin drip that is going to be given to the patients along with the monitoring. 3% sodium chloride is not going to be having any particular role for the management of this condition. Ringer lactate नहीं बताया भाई किसी ने. Sponging not given in the option. So paracetamol से तो वैसे ही नहीं होगा यार कुछ, अगर सीजर हो गया उसको तो. Fosphenytoin. Sure about this? Okay, I'm just making a mention of it. Right? RL. नहीं यार, ये these are the options that were given. At least अगर RL भी होगा, then also you are aware of the fact that normal saline, IV insulin, and potassium is what has to be given to these patients. ठीक है. Then we are talking about the mechanism of action of pegloticase. Now, most of you had an idea about the fact that this is recombinant uricase drug. Now, the only important thing is that you need to remember uricase is what? This is uric acid oxidase, na bhai? Uric acid oxidase. So that is where, if you are familiar with the fact that uric acid oxidase is given the name of uricase, you would have actually picked up the answer as oxidation of uric acid. Xanthine oxidase would be a different drug, na? That is going to be a drug like allopurinol. Urate 1 in renal tubule is going to be inhibited by another drug, which is going to be an example of a drug which is going to be uricose-uric drug. So pegluticase is an example of recombinant uricase, and therefore the answer over here is going to be oxidation of uric acid. RL question में था, उसमें नहीं था, मैं भी तो वही बोल रहा हूँ भाई. Next one that we talk about was the patient who was having a presentation in the form of development of gastroesophageal reflux disease, and the patient was having persistent symptoms despite taking PPI for several weeks. He has a report of regurgitation and bloating, and the physician considered switching to a drug that can titrate the LES and promote gastric emptying. Now, this combination, this is again a repeat question, that when you're talking about any drug which is going to be responsible for increasing the gastric emptying, but at the same time responsible for causing more tone at the level of the sphincter, we are thinking in terms of a drug that is going to be a prokinetic drug by the name of metoclopramide. Please do understand, some of you were getting confused with option number A. Vonoprazan is a potential question for his exam. It's an example of a drug which is going to be working by reversible inhibition of gastric acid secretion. Omeprazole is going to be obviously not functioning in this patient because the patient is already taking PPI. So that's an example of an irreversible inhibitor which is going to be suppressing the acid secretion. Sodium alginate is another potential drug because it is going to be responsible for the formation of a frothy layer. So it is not going to be allowing the acid to come in contact with the sphincter, and therefore it is going to prevent the irritation of the lower esophageal sphincter, right? So this is going to be a straightforward question, metoclopramide. Pantoprazole कर दो यार, एक ही बात है ना, PPI तो PPI रहेगा, Rabiprazole कर दो, Pantoprazole कर दो, that would not make a difference, right? Next that we talk about is 60-year-old man with chronic kidney disease presenting to OPD with paleness, progressive dyspnea, and signs of congestive cardiac failure. His lab results show you normocytic normochromic anemia. CKD is going to be having normocytic normochromic anemia because there is a kidney problem, so the body is not producing sufficient amount of erythropoietin. And to take care of his anemia, you have to give erythropoietin from outside. Now, erythropoietin has a short half-life, so you have to give an analog which is going to be having a longer half-life, and therefore the answer is going to be darbepoetin alpha. This was very similar to the question which came in the FMGE July 25 exam itself, in which he asked you about the CKD and the kind of trouble that is going to be seen in the patient, right? So all of you are familiar. In such patients, iron supplementation is not going to work unless and until you're going to be giving something like darbepoetin alpha. The other indication of giving a drug like darbepoetin alpha is if my patient is having HIV and he has been given a drug like zidovudine, and because of zidovudine, he's going to be having a development of bone marrow suppression. So anemia which is seen because of zidovudine associated bone marrow suppression is the other indication for giving darbepoetin alpha. That is what you just need to keep in mind. Talking about the next one, this was a patient in which patient was a college student having high-grade fever, headache, and mucorigidity, and he was having the presence of neurological examination in which different signs are positive, suggestive of meningitis. What he was also showing you was presence of increased opening pressure, suggestive of infection, turbid appearance. That means something is not well. That's typically going to be seen in case of bacterial meningitis. High protein, low glucose, again a modified version of the question asked in the FMG exam as well. And the gram-negative showing you gram-negative diplococci. So all in all, I can say the fact that my patient is likely to be suffering from a condition. This is going to be meningococcal meningitis. Right now, this is therefore becomes an indirect repeat question. This is a PYQ because once you are familiar with meningococcal meningitis, you are either going to be giving a drug like rifampicin or you take care of it with the help of drugs like the fluoroquinolones. Fluoroquinolone is not given as an option over here, so therefore the answer of choice over here is going to be rifampicin. Right? So drug of choice for chemoprophylaxis for meningococcal meningitis, that is going to be rifampicin. Filgrastim इसमें कैसे हो सकता है यार? Filgrastim कैसे करेगा इसमें? That can just not be there. Last वाले में. Okay, maybe here the chat is coming a bit delayed. Okay. Next one that we talk about was, I hope you did not make a mistake on this one. ये तो आसान था question. 28-year-old woman who was having recurrent episodes of sudden onset of palpitations. She was having dizziness and mild chest discomfort. ECG shows presence of paroxysmal supraventricular tachycardia. The question was not about treatment of supraventricular tachycardia by prophylaxis. PSVT ka prophylaxis is done with the help of calcium channel blockers. And the best drug for this particular condition happens to be oral verapamil. So in case the question would have been asking you about the treatment over here, the treatment obviously is done with the help of a drug like adenosine, which is a drug which is having a short half-life, right? All of you know that. But the question was about prophylaxis of PSVT, and therefore the answer over here is going to be oral verapamil, right? Next, we make a mention of the fact 38-year-old man having the presence of chronic cough, fever, significant weight loss, having chest X-ray shows you upper lobe infiltrates and sputum is positive for acid-fast bacilli. So this is suggestive of TB. He's also having the presence of HIV. I'm absolutely sure that in case of PSM also you read the same condition. In any patient who's having a co-infection in case of HIV plus TB, please take care of the bacteria first. Always we say B पहले आता है भाई alphabets के अंदर, उसके बाद virus आएगा, V आएगा. So take care of the bacteria first, start the patient on ATT, and then initiate the patient on antiretroviral therapy after a gap of at least couple of weeks. So they are not to be started immediately. You never take care of the virus first. It is always bacteria first. try to reduce the transmission of the disease from this patient to other people in the community, and then take care of his HIV condition as well, right? Then making a mention of again a question which is overlap between pharma and PSM, 40-year-old man having the presence of newly diagnosed HIV infection, low-grade fever, productive cough, weight loss. The gene expert reveals presence of Mycobacterium tuberculosis with rifampicin resistance. Now, when the question is talking about the fact the patient is having HIV plus TB and he's having rifampicin resistance, that means, and he's having a CD4 T cell count of 110, you have to start this patient on BPAL regime. Now, what is the other important thing that you should never miss out over here is that these patients have to be followed up for development of what is given the name of iris syndrome. Remember the fact some patients after initiation of the antitubercular therapy are going to be having paradoxical worsening of their manifestation instead of improving. That is what is being given the name of the iris syndrome. So paradoxical worsening after starting of the drug therapy in the patient is what you just need to remember over here. प्रिवेंशन और प्रोफाइलैक्सिस एक ही बात थी ना डॉक्टर साहब, तभी तो आपने कैल्शियम चैनल ब्लॉक कर दिया ना, इसीलिए आपने गलती कर दी ना एड्रेसिन वाली। कोई बात नहीं, अब जो गलत हो गया उसके लिए कुछ नहीं कर सकते भाई, यू जस्ट बी हैप्पी कि एटलीस्ट बाकी ठीक कर दिए। Then making a mention of the fact that the patient was having some kind of a problem because of ischemic cardiomyopathy, he was having the presence of palpitations and narrow complex tachycardia. Eventually, the question was about that amiodarone has been given in this patient. So in case of the first thing that I think Govind sir talks about with respect to the antiarrhythmic drugs, he makes a diagram of the cardiac action potential. And amiodarone is an example of, all of you are familiar, it's a broad spectrum antiarrhythmic drug. Nonetheless, in the classification, it's an example of a class 3 antiarrhythmic drug. Class 3 antiarrhythmic drug means it's a drug which is going to be acting as a potassium channel blocker. So therefore, by sheer logic, this is going to be an example of a drug which is going to be responsible for the phase 3 repolarization, that is the side. In fact, that is also the reason why this is one of the examples of drugs which is responsible for causing widening of the QRS complex in the patients, right? And therefore, it can be given for all types of arrhythmias except for what you're already familiar with as an applied aspect of this torsadisty pointis, right? So, ये वाला question I hope सबका ठीक हो गया होगा. Then making a mention of 55-year-old man, I think Praveen sir already made a mention of this, schizophrenia patient who was on chronic haloperidol, and the question was having the presence of involuntary repetitive movements of the mouth and lips, described by the caregiver as rabbit-like chewing movements. So this is a classical description of tardive dyskinesia. The moment we talk about tardive dyskinesia, the clinical picture and the fact that it is developing 3 years after initiation of a drug like haloperidol, which is a typical antipsychotic drug, would make it absolutely clear that this patient has to be given a drug which is going to be a VMAT inhibitor, that is going to be a drug that is given the name of valbenazine, right? So I'll not waste too much of time on this one. Next, we talk about the fact 45-year-old man who was having hypertension, he was started on hydrochlorothiazide 3 months ago. He's now having the presence of a flank pain and imaging confirms the presence of a renal calculus. So what is the likely reason? So as we are familiar with the fact that it is a loop diuretics which are going to be losing calcium. But when you're talking about something like hydrochlorothiazide, it is an example of a drug which is going to be responsible for causing reabsorption of calcium, right? So a mechanism that is going to be seen in this patient is going to be decreased excretion of calcium. In fact, I mean, this is something which is going to be a paradoxical situation. Thiazides are going to be given for reducing the risk of development of recurrent renal calculi, right? So I'm not too sure whether this question made a mention of the fact that he was initially having a nephrolithiasis, then he was perhaps started on thiazides. And this was the reason why you starting a patient on thiazide after he is going to be having the presence of the history of nephrolithiasis, that you are going to be taking out calcium away from his urine. So you are going to be making the urine less saturated, right? So reduced excretion of calcium is going to prevent the development of recurrence of a patient who's going to be suffering from something like nephrolithiasis. Psychiatry वाला recall ज़्यादा अच्छा था, ठीक है भाई. It's all in the family, na? Whether it is being done by Praveen sir or is it being done by Govind sir doesn't make a difference. Na? So I would say that ये smiley बनाती मतलब that was a better recall. Okay. Talking about the next one, HIV positive patient, female patient presented to the hospital in the 3rd trimester. Her viral load was 1200 copies per ml. She was started on antiretroviral therapy. She gave birth to a healthy baby at 38 weeks by normal vaginal delivery. So when you're talking about a HIV positive female who's going to be having a birth being given to the baby, then obviously what you want to have over here is that you don't want the baby to get affected with the virus, and therefore the prophylaxis has to be given. So the question typically is asking about how do you reduce the risk of vertical transmission. So zidovudine plus nevirapine has to be given for 12 weeks. And of course, exclusive breastfeeding has to be continuing in this condition. So continue breastfeeding for this particular, in this particular situation. यार वो क्वेश्चन में ना हो सकता है उल्टा लिख दिया हमने, मतलब the point was the patient was a known case of nephrolithiasis and then he was started on thiazides. So ultimately what he was asking you about is what is the effect of thiazides on calcium levels. So thiazides are responsible for enhancing the absorption of calcium and therefore decreasing the saturation of urine, reducing the risk of development of recurrence of the stone. CD4 काउंट अननोन था, अननोन कर दो यार, उससे क्या फर्क पड़ता है। 35-year-old man has been diagnosed with pheochromocytoma after presenting with episodic headache, palpitations, and hypertension. Imaging confirms an adrenal mass, and he's scheduled for a surgical resection. So again, a question which was borrowed. I mean, presence of palpitations, headache, and episodic hypertension, along with the presence of increased vanillyl mandelic acid and metanephrines, is suggestive of pheochromocytoma, which is a drug that is going to be given for controlling of his BP preoperatively. None of the drugs, except for what is mentioned over here, phenoxybenzamine, which is an example of a non-selective alpha blocker, is being given for the control of the blood pressure of this particular individual. ठीक है. Then we are making a mention of a patient undergoing surgery which has been administered a neuromuscular blocking agent, and after administration she is having a development of flushing, hypotension, and bronchospasm. Now the moment you're thinking in terms of an NM blocker, neuromuscular blocker being given, which is going to be causing muscle relaxation and is going to be causing hypotension and bronchospasm, the first drug that would be coming to your mind is going to be atracurium. Of course, you're pretty much clear with the fact that when we're talking about atracurium, you will be associating with another question for the people who are going to be giving the subsequent exams, Hoffman's elimination. Right? Next one that we talk about is 32-year-old woman. She is 3 days postpartum after a cesarean section. She has multiple risk factors for development of venous thromboembolism, including obesity and prolonged bed rest. She is hemodynamically stable and breastfeeding her baby, which of the following is a drug of choice to prevent postpartum venous thromboembolism. So when we are talking about postpartum, you do not have any kind of a risk so far as the baby is concerned. I mean, normally the problem that you would expect to have when you are giving a drug like warfarin is that warfarin crosses the placental barrier. And you do not want the child to have a development of fetal warfarin syndrome. But this question is asking about the postpartum period. Mein baby has already been born. So the best drug that is going to be given is going to be an anticoagulant drug like warfarin. Right? 3 days नहीं होगी, ज्यादा होगा 10 year. LMWH क्यों दोगे भाई? LMWH is an example of a drug that has to be given parenterally. Can you imagine if a patient is going to be having a high risk for development of thromboembolism, you would not like to give a drug which has to be given by the parental route here. You cannot be inserting a patient with needles on an everyday basis. You would have to give a drug which has got a higher compliance rate and is going to be causing minimal damage at the level of the body. Right? That is why. नहीं, you normally start off with prophylaxis के लिए आप कैसे start करते हो वो तो point पता है ना आपको. You start off with something like warfarin and LNWH, and this is just for the fact that you don't want to have any kind of a complication. But gradually you are going to be withdrawing the LMWH ना. You would be giving the patient long-term therapy is going to be done with the help of warfarin only ना. So इसमें अगर single drug आप दोगे तो warfarin देना ही पड़ेगा आपको भाई. Reason बता दिया मैंने. Right? Then next question is what is going to be the drug which is raging as of now? Type 2 diabetes. The patient is on metformin. His HbA1c level is 8.2, which is that means a reflection that it is uncontrolled. He has now been diagnosed with heart failure with reduced ejection fraction. And which of the following drug is the most appropriate? So it's a combination of a patient having diabetes with reduced ejection fraction, heart failure, and therefore the drug that is going to be extremely effective for both these conditions is going to be the SGLT2 inhibitors. That means a drug like empagliflozin. Empagliflozin. The every educator is not going to change the answer. We are all going to be talking about the answer with our own understanding. We can always have a healthy discussion as to which one is going to be present and which one is going to be not preferred. Right? Then making a mention of a 30-year-old woman who is going to be having a history of bronchial asthma. She has been given salbutamol and ipratropium meter dose inhalers as needed. She reports frequent nocturnal symptoms, including wheezing and breathlessness that wake her up several times in a day. What are the most important next step in the management? So this is all about the GINA guidelines, that if your patient is already taking a drug, which is the SABA, salbutamol, and she's taking a combination with anticholinergic drug, then you would have to take care of her symptoms, and that would be done in association with the GINA guidelines. You would be adding a LABA and inhaled corticosteroids. Right? इसमें confusion है LMWH वाले में, we can still have a discussion about this one here. So I will just put a question mark over here in case you feel that there is something which is going to be missing over here. So that takes care of a discussion of the 20 questions that came from the subject of pharmacology. In case of any confusions regarding either the options or the answers, I mean, we can have a healthy discussion. Please do let us know about the same. And I think it is time for me to hand over the mic to Vegdan sir for discussion of the PSM questions. Thank you so much, sir. Sir, you're muted.
Okay, it is fine now, sir.
Absolutely, sir. Thank you so
Okay,
much.
friends, let us start with PSM. PSM, I got around 21 questions. I've excluded 2 or 3 which were covered in pharmacology or other subjects. Let's come to the 19 questions. You'll be happy that at least 15 you must have attempted correctly. So let's go through them one by one. Try to help me reconstruct the questions in a better way. I'll look at the chat box. You can keep on helping. So first question was, there was a city with 70 lakh population. 30% population is living in slums. We were asked about how many urban PHCs should be there. And as we have discussed in the mission classes, one urban PHC, that is urban health center, that is for a population of 50,000. So 70 lakh population, and we have 30% slums. So this is 21 lakh population, which is in slums, and you want to have urban health center. One urban health center is for 50,000 population. So this will give you a total number of 42 urban PHCs. So that was the easy thing. You knew one urban PHC is for 50,000 population. In urban areas, health center is for 50. For 21 lakh population, if you are looking at slum population, 21 lakh population, you will require 42 such centers. So I'm sure 100% of you must be correct in this question. This was another easy question. Remember in the mission classes, I showed you a diagram showing a die where you roll and do randomization in RCT. So this is exactly same. First ever step in RCT is to select the population, which is not given. So here the first step will become randomization. After doing randomization, now you give intervention or manipulation. After intervention or manipulation, you do the follow-up. And finally, you will do your statistical analysis. Remember the intention to treat trial also that we discussed. So this will be 4, 1, 3, and 2. Choice number C. Right? So this is 4, 1, 3, and 2. I'm sure 100% of you must have marked it correct. Analysis always come at the last. Randomization is done while dividing them into experimental and reference group. So this must be correct for all of you. I'm looking at the chat box. That's great, Dr. Pratipal Singh. Your answer was correct. Great. No, randomization is always done before manipulation or intervention. Before manipulation. Once you do the randomization, उसके बाद ही तो intervention दोगे ना, right? Okay. Good. Dr. Flash, you are right. Let's move further. This was again a easy repetition. I think for this particular topic has been going on since last so many years. Vaccine vial monitor, what we discussed in the mission classes and marathon classes. If inner square is lighter than the outer circle, definitely use the vial. So you can use vial number 1, vial number 2. Look at the vials carefully. Vial number 3 and 4 have to be discarded. Please confirm if image was same. Okay, order may be different. Order doesn't make a difference. I'll tell you. If inner square is lighter than the outer circle, use the vaccine. So you must have seen first and second. They only are to be used. In case order was different, select those two where inner square was lighter than the outer circle. Where we cannot use, if inner square is of the same color or darker, then you cannot use the vial. You will have to discard the vial. Okay, image was same. Image was same. Great. Okay, friends. So I am presuming all 3 questions of yours are right till now. Similarly, you must have made this 4th question also correct. Research study, mammography is used for screening breast cancer, and it was found to have a favorable outcome in mortality. It increased the 5-year survival rate. But in reality, forensic post-mortem autopsy examination, there was not much difference found in mortality. Remember the concept, why do we do screening? The concept of lead time. I showed you a diagram of natural history of disease in which there is screening time, lead time. Early detection, better treatment, better prognosis, better survival. So I told you, if someone is studying those patients, it will appear they have an apparent increase of 5-year survival because you are detecting the disease early. But in reality, disease has to follow its natural course. So this error is lead time bias. You are leading the time of detection of disease. You are leading the time of detection of disease. Okay, I'm making a note wherever you are correcting the choices. You are correcting the choices. Yes, lead time you can say same as detection. Very right. You are absolutely right. Okay, now this question, there are two types of questions have been given by the students. I'll tell you answers to both the questions separately. Whichever question you have read, because both students are adamant my question is correct. If they asked you Anemia Mukt Bharat and they asked you adolescents, students mentioned in the question it was given on a weekly basis, then your answer is going to be 60 milligram elemental iron, 500 microgram of folic acid. 500 microgram of folic acid. Now, in many students are saying this was not given. What was asked was WIFs. Friends, what is WIFs? WIFs is older program that is weekly iron folic acid supplementation. This program stopped in 2018 when Anemia Mukt Bharat was launched. So if WIFs was there, then your answer will become choice number D, which stopped in 2018, because 2018 Anemia Mukt Bharat came, where answer is choice number C. So depending on the question, okay, WIFs. If WIFs was there, answer will be D for Delhi. In WIFs, it was weekly iron 100, folic acid 500 given to all for 52 weeks continuously in a year. Right? Okay. Then there was a question on 3-year-old rickets, malnourishment, growth is less than 5th percentile, no exposure to sun. Which program will cover this deficiency below 6 years of age? Remember the beneficiaries we discussed for ICDS, 0 to 6-year children. So many clues were given in this particular question. Answer cannot be midday meal program because it is meant for school children, 6 to 14 years of age. Then we are not looking at anemia only. We are looking at rickets, malnourishment, growth. So ICDS growth chart would also be utilized, right? Okay, many are saying WIFs were given, many were saying WIFs were not given. Depending on that, therefore, I have told you both the answers. Anemia Mukt Bharat 60 and 500 weekly, WIFs 100 and 500 weekly. Both give weekly iron folic acid supplementation. So this is below 6 years of age. ICDS is looking at nutrition. We can give 1/3 calorie and 1/2 protein. And we will double the supplement now for that child because he or she is malnourished, right? Yes, National Nutritional Anemia Prophylaxis Program, or even if Nutritional Deficiency Prophylaxis Program, it will not be the answer. Now, there is a question on Nelgonda technique for defluoridation. Remember in the mission classes, I told you the mnemonic for 3 chemicals. Yes, that mnemonic is lab. So we have lime, alum, bleaching powder in this sequence. I told you in many books, this sequence is not given correctly. This is the correct sequence. So you have to give lime and alum. So answer will be choice number C, 2 and 4. 2 and 4. Yes, we'll go faster. Then there is a question on patient presenting in Chittoor, Andhra Pradesh, bowing of legs. Andhra Pradesh, bowing of legs. I've shown you also the photograph also. In the mission classes, this is fluorosis. He complained about bone pain, stiffness, restricted movement. That is also supporting fluorosis. So what you will not help in this patient's management is fluoridation. He's already having excess of fluorine. We cannot fluoridate the water. Nelgonda technique will help. Using surface flowing water which has lesser fluorine, changing the source to a safe water is better, right? Good. All of you are right. I can see in the chat box. Look at this question. This was again easy. In fact, same example we took in the biostatistics topic of mission classes. Hemoglobin levels you are comparing in 2 different groups of populations. Hemoglobin levels, not anemia. So hemoglobin level is quantitative data. You will compare mean and standard deviation in 2 groups. So it will be unpaired t-test. Not paired because that is in one group before, after. Not ANOVA because that is in 3 or more groups. Not chi-square bet because that is for qualitative, discontinuous, non-normally distributed data, right? Okay. Then there is a question: in a field visit, epidemiologists found larvae of a mosquito. They have written everything in the question. Resting parallel to water surface. I am sure I have shown you this image at least 5 to 6 times in the actual classes also. So this is Anopheles. They have mentioned no siphon tube, palmate hair on abdominal segment. This will not be required because resting parallel to water surface to take the oxygen directly. This is Anopheles. 100% of you were correct, right? Okay. Then this was a question where many students got confused. You will help me to find the correct answer. It is an intervention trial. So cross-sectional, case control, ecological cannot be the answer. It has to be a trial or an experiment design. Now friends, what is the major difference? In clustered randomized controlled trial, as the word is telling you, randomization is done. So randomization is done. Whereas in quasi-experimentation, this was a new question, randomization is not done. So think about the question and tell me, was randomization mentioned in the question or not? Okay, in the previous question you are saying this one, mean hemoglobin was mentioned. Yes, mean, even if it is mentioned or not, hemoglobin levels they are saying. So it has to be yes, parametric test, unpaired student t-test. Okay, can you tell me in this question, friends? Think carefully. Was randomization word mentioned in the question? That 20 and 20 PHCs, 20 and 20 PHCs were randomly chosen. If it was not mentioned, then your answer will become quasi-experimental study. Because question which is written in front of you on the screen, randomization is not mentioned. So if randomization was not mentioned, it is quasi-experimental. But if they say 20 PHCs were chosen randomly to follow standard treatment, 20 were chosen randomly to follow community-based treatment, that will become clustered, right? Okay, so good, very good. Let's move further. Then this was a straightforward question. Entry of organism till its maximum infectivity. I told you in the mission classes, it is generation time. Only thing you have to differentiate it from the generation time of microbiology where organism doubles, right? Okay, so that was easy. Let's move further. This was another easy question. POXO Act. If you remember, in the mission classes, I told you all the age groups in National Health Programs of India. When I mentioned a child, what did I tell you? Age group is 0 to 18 years. And this is not just WHO definition, but Government of India RCH program and forensic legal definition also. So child is anyone who is less than 18 years of age, that is covered by prevention of children against sexual offenses, right? So this was an easy question. So this we have to remember, child is always 0 to 18, except in Factory Act where it is 0 to 14, except in ICDS where it is 0 to 6, right? Okay. Question 14. This was another new question. Infant and young child feeding guidelines. Now quickly I'll tell you, if it is 6 months age group, it is 2 to 3 tablespoonful. If it is a 7 to 8th month child, then recommendation is 2/3 of katori. That is given 3 times a day. But if a child is 9 to 11 months, we make it 3/4 katori. That is given 3 times a day plus 1 snack. And finally, when we look at 12 to 24 months, then it is 1 full katori, which is given 3 times plus 2 snacks. So many places it is also mentioned that it is given 5 times a day in 12 to 24 months. Now students was convinced that they asked about a 7-month-old child. So 2/3 katori 3 times a day, half to full katori was given in all the choices according to student. So that will become choice number A. Choice number A, right? So 3 times it is given 2/3 katori, which falls into given in the choices, 1/2 to full katori, half to full katori, right? Along with breastfeeding, this is for complementary feeding. These are known as IYCF guidelines. I thought you must have covered this in pediatrics. Okay. Then this was a new question. Many students were very worried about this question. Every exam has one or two new questions. Don't worry about that. See, de facto system, you have to think logically also. When you are doing census of India, enumerators will come house to house. So if someone is present there, then only their data can be collected. So census actually goes de facto, where individual's location is used during the enumeration period. Friends, please remember de facto is an English word. That also tells you same, that location during the enumeration period. Yes, this was a totally new question like the previous one. So I told you out of 19, 3 questions were totally new. But out of other 16, majority of students have attempted 15 correctly minimum. Let's move further. Then this was a direct question. COVID-19 disease, died after 15 days. His death was reported in the system. This is a type of passive surveillance. Remember in mission classes, I told you, passive surveillance, patient reports to health system on his own. Active surveillance, health system goes to community to detect cases. Sentinel surveillance, this is to identify hidden or missing cases. Syndromic surveillance is to predict outbreaks, that outbreaks are going to occur, right? So this is directly coming to hospital, dying there. This is passive surveillance. Passive. Yes, majority of questions were logical this time, Dr. Divyansh. I'll tell you one more question later where you will find logic helps you solve the question. Question 17 has already been covered. I am including here, it's a pharma question because it's mentioned in PARC. It is rifampicin. Rifampicin. Okay, and one question, please confirm with Dr. Govindrai Garg sir and Sparsh sir. That was related to a woman who was started on ART 4 weeks and then delivery occurs. Then the newborn will require only nevirapine as per the National AIDS Control Program guidelines that you can confirm with JRG sir also. That is ART if taken for 4 weeks, then nevirapine will only be required. Please make a note of that. Okay, friends, this was a question which I am sure you have marked logically correctly. Fulfillment of objectives, achievement, targets, and short-term goals of a program. I told you in the mission classes what is monitoring? Continuous overlooking the activity, how the program is going. Surveillance is systematic, watching the progress of a program along with attention, authority, suspicion. This is evaluation. Has my program achieved what I wanted? Have I achieved the result I wanted today from the NEET PG exam? Now you are evaluating your exam today, right? What you have done the preparation in last 12 months. What was the fourth choice? No one was able to tell me. I am presuming it must have been planning. I'm presuming it must have been planning. Okay, thank you, Dr. Nabeen Chandra. You are absolutely right. Thank you so much. So planning, monitoring, evaluation, surveillance is a simple concept we discussed in the mission classes. Okay, question 19th. That was a basic question, very old question of PSM of NEET PG. Oncologist, patient has poor prognosis, chemotherapy, radiotherapy will not improve survival. Friends, all these questions are based on the language given by the students who helped me construct these questions on the Telegram. Some language may not be up to the mark. I will improve the language when I release the final video with your help only. Patient is conscious, anxious, doctor wants to do everything. But now let's be realistic. They have already told that poor prognosis, radiotherapy, chemotherapy is not. So refer the patient to the hospice for palliative care, but only after properly counseling the parents. But after properly counseling the parents, that nothing more is to be done, right? Okay. Okay, friends, in case you find any other question from communication, planning, management, international contraception, biostatistics, do let me know. I wish you all the best. Out of the 19 questions, I am expecting many of you have got 15 and above correct. Only de facto, only infant young child feeding guidelines was a totally new question. Other questions were what we have already discussed, we have already studied. Right, so friends, I wish you all the best. Now we have next in line.
Sir, I'm there, Dr. Pooja.
Okay, Dr. Pooja is there. She'll be taking up physiology. Thank you, friends, for your time.
All right, guys. So there were not many questions from physiology, right? There are 6 or 7 questions, and we'll go quicker as I can see that you guys are tired, right? So just give me a minute so that we can start. So yeah, first question was from this length tension relationship. I hope you are able to see my screen. And it was a very easy question. What they have asked is they have given the B2C, that means this much. That is the highest optimum length they have given. And we know optimum length means maximum actin-myosin cross bridges, right? So what you can see over here, the actin and actin is overlapping on each other, right? And the myosin heads are way apart, right? But over here, what you see, there is a maximum actin-myosin cross bridging, wherein here in these two things, what you can see that myosin heads are empty. That means there is no maximum actin-myosin cross bridges, right? So the most appropriate answer over here, wherein you can see the maximum actin and myosin cross bridging. Remember, not actin and actin. This question we have taken in the E&Ds also, and it is there in the mission classes also, right? VQ curve. VQ curve, we talked about it, ventilation perfusion curve, isn't it? I told you that whenever you're going to go from normal towards downwards, when the PO2 is high, when the PO2 is going to be high, whenever there is a higher ventilation but lesser perfusion, isn't it? I told you go with the numerator and denominator like that, right? What they have given is complete block of the this perfusion. That means there is no perfusion. That means perfusion is 0. So ventilation is only ventilation is there. Of course, the air is not going to get exchanged, and point D is going to be the answer over here, right? So point D is going to be the answer over here. All right, we have seen this already. If you go here, what is going to be there? B and A, lesser will be the ventilation and more will be the perfusion, right? So you're going to have a maximum unexchanged air. But over here, we're going to see the atmospheric air-like condition. So option D or point D is going to be the answer. Next, it was a very easy question. Menstrual cycle was given and 28 days ka menstrual cycle is. So 14 days is going to be the ovulation. And they have given that which of the following typically observed between day 21 and 25th. Okay. Point B, previous question, only point B. Only point B, what was that, beta? Only one option showed overlap. All right. So only one option showed overlap. That makes it very, very easy, right? No explanation. All right. So, all right, I will not give any explanation. So 14th day, you know that after that, the estrogen is going to lower down a bit, but the progesterone start to increase. So progesterone cannot decrease. So option B and D cannot be the answer. And LH also is not going to increase after ovulation, right? It is going to decrease. So answer is going to be option A. Next, 2 to 3 times the blood glucose has been raised. That means there is no proper insulin release, or you can say there might be an insulin resistance case that they have given. Basically, you can help me out with this, right? All right, order you can give me, Dr. Nikhil Kumar, please give me the order, beta. Please give me the order. I'll definitely take a screenshot and I'll improve upon it. All right, whatever questions in order option I got, that was the thing. All right, now here the glucose has been continuously increasing, so my insulin cannot fall. Remember that, right? The insulin is going to get increased because glycolysis increases the insulin, right? So it is going to be first rises and then sustain its increased level as the glucose has maintained its own level, right? So that is going to be the better answer over here. It is insulin is not going to rise gradually. That is not going to be there, and it is not going to fall, and it will not remain elevated. If the glucose level are maintained, then the insulin will be maintained too, or it will fall. All right. LH decrease. Okay, Vaishnavi. Let me know instead of which option LH was decreased was there. Okay, I'll change that in the option. Now, the net filtration pressure was asked. This was very, very easy question. We have discussed how to calculate it. HP minus OP minus HP minus OP. Have this slide ready for you if you want. You know, you can go through it slowly. But I have already written all the values. 18, 17 minus X. X means over here we have to calculate the interstitium ka hydrostatic pressure, right? So X, you take it that side, it will be minus 9 minus minus 7, that means plus 7, and the answer is going to be minus 2. I hope this exact options I have got over here, right? All right, chalo. Rises and then maintains steady concentration was in the option. All right, that is the same thing, right? Sustained increase level or steady concentration. Then in the question must be there is maintained, right? Must be. All right, Disha, I'll change it. Thank you, Disha. Let me know if anything else you want to change. All right, then there was a question. Following hormone is responsible for hyperpigmentation. You know, the melanin stimulating high hormone is responsible. In the Addison, there will be low level of cortisol, and there is no, you can say, negative feedback that is going to be there. Aldosterone is low, cortisol is low, so there is no negative feedback on the ACTH, and ACTH is responsible. Okay, chalo. Oncotic pressure. Khandelwal, oncotic pressure was asked. No, there is no FOMO beta. It is -2. -7 becomes +7. All right. All right. Decortisone was there. Okay, the case scenario was decortisone. All right. A man went to a trekking. Let me know. Two people told me, ma'am, there were two different questions on the high altitude. One was this. This was very, very easy question. We have known this question. When you go on the high altitude, hypoxia will be there. Hyperventilation because of the stimulation of peripheral chemoreceptor. That causes hyperventilation, which will lead to CO2 washout. And that is going to lead to respiratory alkalosis. Respiratory alkalosis. Okay, that is going to be there. -9 +7 is going to be how that becomes +2 beta. It is going to be -2 na beta. Okay, next question. Let me know this was the question. Second question. The man is flying on 3400 meters, again a high altitude, but now this time they have asked the mechanism of high altitude cerebral edema. I told you all the systemic vessels, they are going to get dilated except the pulmonary vessels because of the hypoxia, and we have discussed multiple times when we talk about the chemoreceptor that metabolic acidosis, H+ ion changes in the blood is not going to cause any changes in the central chemoreceptor or in my cerebral vessels per se, because it is inside the blood-brain barrier. Hypoxia won't cause vasoconstriction except in the this pulmonary vessels. I hope this cerebral vessels was asked, right? All right. Cerebral vessel was asked, not the pulmonary vessel. Okay. PaO2. Ayush, PaO2 was high or PaO2 was low? PaO2, hypoxia le lo. Hypoxia is low PaO2. Right? You're talking about this. Hypoxia is low PaO2. So that is going to be my most common answer, because vasodilation increases the permeability of the fluid outside of the blood vessels. Right? And PCO2, high PCO2. Yes, it is high PCO2. But again, it is not going to cause the high PCO2 is going to cause. Yes. High PCO2 nahi tha. Low PCO2 was there. Okay. Here it was low PaO2. Low PaO2 cerebral vasodilation is going to be there in the option A, right? Okay. Yahan par vasoconstriction tha. Over here also. All right. So again, vasoconstriction is not going to be there. Okay. I'll change this. Right? Vasodilation will be there because of the hypoxia. PCO2 is not going to be. All right. Both were low PO2. All right. No. All right. So metabolic acidosis was not there. Okay. Any of these questions came, let me know. Ileal resection, somebody told me ileal resection was also there, right? And vitamin B12 deficiency and thyroid uptake. Some question was there related to iodine deficiency. Was it physiology question? Let me know that. All right. So I have not got a proper questions of these. So let me know if these two questions were there. H+ ion wala there, PCO2 was not there, and PaO2 was there. Okay, I'll change that. All right. Cerebral vessel tha to vasodilation hi hoga. And that is all from my side, guys. Whatever inputs ileal wala tha, relatable doctor. All right. Thank you. So that is going to be, please let me know what was the stem of that beta. All right. So that is all from my side. And I'll definitely improve upon the options that you have told me. And next up coming is, I guess, Amrit sir is there. Sir, are you there?
Yes, I am there, madam.
All right, sir. That is all from my side.
Thank you, madam. How are you guys? Hope you had a decent exam. And I will not take too much time because surgery questions were okay, not too bad. You would have gotten most of them right with a decent level preparation. So let's go through them quickly. Yeah. And I'll be seeing your comments. If there is anything which requires any correction, you can let me know. Okay, but they were not the toughest questions from compared to the previous years. So let's see how you did. थोड़े tricky भी थे. It's not that everything was straightforward, right? But some were repeats. So let's do one at a time. They had given an image of the breast. It was a breast malignancy, and there was redness occupying most of the skin, right? Most of the skin was showing redness. So that was looking like a pude orange or inflammation more than 1/3. And if it's more than 1/3, it is going to be inflammatory breast carcinoma. That will be T4D, right? So answer here is going to be T4D. This is a repeat question. Okay. They had shown an image of varicose veins in the lower limb, and they had asked what is the true statement. So only veins were seen, so it is not a C6 stage. That would have been maybe C2 if only veins are seen. Sclerotherapy is only used for early varicosities. It is not used for advanced varicose veins. There the treatment is EVLA, you know, it's our favorite surgery. It can progress to eczema and ulceration. This is true. Okay, usually varicosities are idiopathic. They are primary. Pelvic mass is not the commonest cause. Okay, so there here the answer is simple. It can progress to eczema, ulceration, all those complications were seen. Okay. I guess some of you made a silly mistake in this. I don't know. They had shown an image of a wound being sutured, and they had shown the knot, and the knot looked like this. This is a surgeon's knot. Okay, I hope you didn't mark square knot or granny knot, because remember, granny knot and square knot have just two loops. It's a single throw. है So they have just two loops. Here you can see there are four loops. So four loops means it is going to be a surgeon's knot. Okay, it's not going to be a reef knot or a granny knot. Here also there should not be any controversy. Patient, they had given the age, I don't know. And they had said person has a progressive dysphagia, regurgitation, weight loss, could be achalasia, could be C esophagus. But the barium image was very classical. It had showed the gradual or a smooth tapering. In fact, they had shown the lung also. Okay, they had shown lung also where person had some aspiratory pneumonitis features. So they had asked what is the test for diagnosis. So test for diagnosis, of course, is going to be manometry. Don't think it was C esophagus. Okay, the scenario was suggestive of achalasia. It did not suggest C esophagus from the recall that I've gotten from the students. So best answer will be manometry. Yeah, option D was esophagogram. This is actually esophagogram only. So I don't know why would they put this. This was one of my predicted questions. They had shown an image, anatomical image of an anal fistula. I believe it was this one. Okay, I believe it was this one. So this is going to be intersphincteric. The fistula tract passed between the two sphincters. That is type 1 according to Parks. So it was intersphincteric. That is the recall I got from the students on the image. These are the other types. They had shown a photo of PDS suture. Okay, but they had not shown the properties, and they had asked you what type of suture material it is. Of course, PDS is monofilament. No doubt about it. Polyfilament and braided are the same. Okay, polyfilament and braided are the same. They mean the same thing. Another easy question. They had shown a specimen of a total thyroidectomy. Here I didn't get the other options, but they were systemic complications. So they had shown total thyroidectomy, and they had asked what complication will occur after 2-3 days. So person can get hypocalcemia because of ischemia of parathyroids that can lead to carbopedal spasm. Okay, because of hypocalcemia. Other options, I believe, were systemic complications. They were unrelated to thyroidectomy. Yeah, they were unrelated to thyroidectomy. Yeah, PDS and polydioxanone mean the same thing. Yeah. So maybe PTH was accidentally removed or it was ischemic, it doesn't matter. Answer, the other options were really not related to thyroidectomy, is what the students told me. Yeah, mouth deviation, very good. That means you thought it was a nerve injury during parotid surgery. So mouth deviation may be okay. Trismus, okay, fine, means the same. Migratory thrombophlebitis, okay, good options. Very good, thank you for that. Another nice question. Elderly male, you know, whenever there is elderly male, you think of malignancy. Had a jaundice, weight loss, pruritus, scratch marks, palpable distended gallbladder. This is a CA head of pancreas. Okay, this is called as Kervoiser's law. It is not a CA gallbladder. Okay, CA gallbladder will rarely present with a mass. It will be palpable. Okay, CA gallbladder is usually not going to be palpable. But yeah, gallbladder is palpable in periampullary or CA head of pancreas, according to Curvoiser's law. Yes, non-tender. That's fine. That's fine. Non-tender. They are also given the bilirubin levels. We don't even need that, honestly. Okay, we don't even need that. Anorexia, weight loss, fine. Okay. So as per that law, it is periampullary carcinoma or CA head of pancreas. Students gave conflicting views on this. There was an image of bile duct injury. They had asked you Strasbourg type, and definitely there was a leak. So it cannot be type B, and it was not CHD. Student said, sir, maybe it is cystic duct, maybe it is right posterior, not sure. But in my opinion, it was type A because cystic duct you can easily make out. So it should be type A. And please understand, if there is a small aberrant duct leak, it's also going to be type A only. It's not type C. Type C will be right posterior. This one, this big duct, that is right posterior duct is cut. So yeah, type A image, I'm sure. So this is a repeat question. This was asked in INI-CET as well as in FMG. Okay. Right. Another easy question, patient had burns. They had shown a mannequin. They had not shown an actual patient. And they had shown image of eschorotomy being done. And they had asked, what is the purpose of doing eschorotomy? Okay, what is the purpose of doing eschorotomy? It is done for circumferential burns, basically to prevent compartment syndrome. Okay, it is done to prevent compartment syndrome. So they had shown this image, eschorotomy. It is typically seen in full thickness circumferential burns. Okay, it was not a skin graft. That's what students said. It didn't look like skin graft at all. And it's nothing to do with vascular protection. That was the other option. Painless bhi de rakha tha. Even better, it is full thickness. Okay, because full thickness burns are going to be painless. Even better. Okay. Question you have fought with me over many times. Okay. A patient with penetrating trauma presents with hypotension, so he was unstable. He had findings supposedly of peritonitis. What will you do next in penetrating trauma? You are going to do laparotomy. Peritoneal lavage is not done anymore. Okay, there is no diagnostic peritoneal lavage, and you can't wait and watch in an unstable patient. So obviously it will be laparotomy. We have discussed this many times. This is a FMG question. It was asked in FMG. Following a building collapse, patient has airway obstruction. He has things in his mouth. There is soot collection or dust was collected in his throat. He had airway obstruction. And if he has airway obstruction, this procedure is done. This is needle cricothyrotomy. And they had asked, what is the true statement about it? Can provide ventilation for 6 hours? No, it can provide for maybe 15 to 30 minutes. Okay, not more than that because it's a needle, it's not a secure airway. Will be followed by tracheostomy is the correct answer. Okay, will be followed by tracheostomy is the correct answer. Peritonitis mentioned, even better, even more the reason to go for laparotomy. USG abdomen is not done in trauma. You do USG fast, not USG abdomen. Okay, and CT abdomen, obviously you won't do in an unstable patient. CT abdomen is done only in a stable patient. And this is a repeat from NEET 2020. Anal canal lesion or anal canal malignancy. It was distal to the anal, around the anal verge, lower anus. Will be drained first to which lymph node? It will be superficial inguinal. Okay, it will be superficial inguinal. Right. So that was the anal canal malignancy drainage. There were some questions which will be discussed by the relevant faculty. There was a child's photo with phimosis and he had a white patch, that is balanitis, BXO. It's actually a derma cum pediatric question. There was an MCU image. There was an image of hand gangrene, which Spurs are discussed, so I won't discuss it here. I believe that was wet gangrene. Okay, I've taught this in the classes, right? So these were some of the questions. Some are overlapping, but as such, with basic level of preparation, you would have gotten most of the questions right. So I hope other subjects were also equally well managed. Now I will hand it over to Dr. Janvi and she will be doing the anesthesia questions. English then.
Hello everyone. So I got only two major questions from anesthesia and they were super duper simple. The first one was that there was a patient undergoing a surgery and for anesthesia he was given sevoflurane and then there was exposure of after exposure of sevoflurane there was the classic signs and symptoms muscle rigidity, hyperthermia, rise in EtCO2. And the direct answer was dantrolene sodium. Yes, exactly as Weber was saying, all the questions from yesterday's class. In fact, we had a mission yesterday, and I think the questions, all of them came from the same mission. So good for everyone who attended it. They had asked the management of malignant hyperthermia over here, and the answer was dantrolene sodium. The second question, super easy. While undergoing a surgery, a muscle relaxant was administered, and patient had a reaction which was similar to histamine release. That is, there was facial flushing, hypotension, and sort of an allergic reaction. So identify the muscle relaxant, which was atracurium in this case. As you guys know, cis-atracurium does not release histamine, but atracurium releases histamine. So that was the answer. Yes, I had mentioned it many times in the class. And there was another question. It's not really anesthesia related, but a few students were asking me. There was a pediatric patient who had eaten a peanut and he was choking on it and he was taken to the ER. As I believe the patient was unresponsive. So I have done this in my marathon class where I've discussed that if there is a foreign body obstruction and the child is unresponsive, you will start CPR. If the child is responsive, you will give all those back blows, chest compressions, all of those. But if the child is unresponsive, you start CPR. So I think that would be covered in pediatrics as well. So these two particular extremely easy questions from anesthesia. I hope all of you all got it correct. Over to Dr. Devyani for the next discussion.
Just a second, I'll be sharing my screen. Hello everyone, can you hear me? I hope you can hear me. I think.
Yes, ma'am.
Okay. So hello everyone. There were around 15 questions that had come from micro. Everything was pretty simple this time. They were mostly previous year questions or previous year topics. So the first question was like a direct repeat from last time, right? And you had been given a history of a child who had diarrhea and extensive nocturnal perianal itching, and stool sample was collected, which was showing the following. Hello everyone. And you had to identify the organism. You were given this photo, I believe, and this is the egg of the Enterobius vermicularis. This is the direct repeat from the previous year question. I think there was also a history that mother was noticing some worms, I think, or some threads in the undergarments or something like that, right? I think this was the question. So this was your plano-convex egg that we have done so many times. And yes, the answer was Enterobius vermicularis. Very, very simple. Moving on to the next one, you had a farmer who had these multiple draining sinuses and black granules were coming out from the regions as given below. And what is the likely microscopic finding in this case? So I believe this is exactly the question that was given. These black colored granules are a similar kind of a picture. Okay, Scotch tape method was given. Okay, got it. Scotch tape method was added. Okay, thank you. White threads was given. Yes, okay, these white threads, I'm adding it. Thank you. Didn't even see the egg even. Very good. Yes, they were all like these questions were all buzzwords this time. So like they were making it extremely easy. Right. So these were the options, I believe. So whenever this is the options, my answer would have been septate hyphae with 4 to 5 microconidia because this is the one that is causing your eumycetoma fungus. There, the diagnosis was mycetoma, right? And among the options, it was the eumycetoma, which presents as your septate hyphae with 4 to 5 micron width, even if that is not important. Good, good. Okay, moving on to the next one. We had a history of a sewage worker that died due to fever, jaundice, and conjunctival suffusion. Again, giving the word conjunctival suffusion has given away the diagnosis of leptospira, right? And we know that leptospirosis causes this very famous Weil's disease, hepatorenal-encephalitic type. So these were the these were the Weil's disease that was there for your leptospira. Why not brucellosis? Brucellosis is not showing us conjunctival suffusion. And sewage worker is pointing us towards this water ka contamination. If it was brucellosis, they would have given you some kind of a milk ingestion ka history, unpasteurized milk, right? So it is going to be leptospira. Okay. Arthrospores are something that is seen in trichosporon, right? It is not something that is seen with your eumycetoma. Okay, conjunctival hemorrhage tha, that is still okay, meaning the same thing. Is still meaning the same thing. Okay. Then we had a patient who presented with fever, cough, and breathlessness. A bronchoalveolar lavage was taken. A KOH mount of the sample showed septate hyphae with dichotomous branching. Again, giving away the answer, septate hyphae, dichotomous branching, BAL sample, respiratory symptom. Everything was pointing towards the aspergillus, right? So everything okay. Slender hyphae tha, theek hai, slender hyphae hoga. Even if it people were saying, ma'am, acute angle branching tha. Acute angle branching था, ठीक है. अच्छा, एस्कैरिस नहीं था, ऑप्शन स्ट्रोंगिलॉइड्स था, ठीक है, दैट इज स्टिल ओके. विच वन? एस्कैरिस नहीं था, स्ट्रोंगिलॉइड्स था, फिर भी फर्क नहीं पड़ता. आंसर इज नॉट गोइंग टू चेंज. एस्परजिलस, वेरी गुड. तो यहाँ तो एस्परजिलस. कैन यू हेल्प मी विद द अदर ऑप्शन? आई गॉट राइजोपस, क्रिप्टोकोकस, बट आई डिडंट गेट द अदर ऑप्शन. I think this was also given in the class. Very, very simple. A photo was also shown. Anyway, we'll move forward. A man presented with a low-grade fever, cough, and weight loss after some kind of a travel history that was given. A bronchoalveolar lavage was put for culture, and direct showed narrow-based budding with within the macrophages, and the culture image is shown below. I think this is what you were seeing in your LPCB. No acute angle written. ठीक है, acute angle नहीं था. Okay. Candida histoco, so our answer was going to be histoplasma, right? For the simple reason, these are going to be your tuberculate. These are your tuberculate macroponidia. And this narrow base budding within the macrophage is telling you the intracellular morphology of histoplasma. So our answer is going to be histoplasmosis, right? Very, very simple. Pneumocystis jirovecii, where was this? Enterocryptococcus. One option was blastomyces. चलो ठीक है, इसको blastomyces कर देते हैं and एक को pneumocystis कर देते हैं. Even if so, the answer is not going to change. It is still going to be histoplasma. Then I believe there was a question where a patient had edema of the lower limbs and a peripheral blood smear was showing this organism, and you were asked the likely cause for the edema. So these are your filarial worms, right? These are your filarial worms. And yes, so these are your filarial worms, and we know that they are by the obstruction of the lymphatic vesicles. Very, very simple. Very, very simple, because obstruction of the lymphatic vesicle, filarial worm, this is what they do, because of which patient is having elephantiasis. Right? Okay. Pneumocystis for dichotomous question. Yes, मैंने add कर दिया यहाँ पे. अच्छा, for dichotomous question. Okay, no problem. यहाँ पे add कर देंगे. Pneumocystis. ठीक है. Again, that is still not the answer. Last question, aspergillus. कौन सा question aspergillus? Are you talking about this one? These are your tuberculate macroconidia. So no, that is not the answer. Okay. Boy with an old age home owner bought raw milk for all the people. Then consumption of this unpasteurized milk was causing bloody diarrhea and vomiting. Stool sample was showing gram-negative bacilli. So what is the likely organism causing this disease? So bloody diarrhea with a gram-negative organism. So Clostridium are gram-positive. Bacilli, Staphylococcus is a gram-positive. Cocci. Vibrio parahemolyticus and Campylobacter both can cause your dysentery, but Vibrio will be given a history of like a sushi or a seafood intake, right? So our answer here is going to be Campylobacter. We know it kind of spreads by unpasteurized milk also. Or some kind of a poultry is also there, right? So our answer is going to be Campylobacter. Vibrio is not going to be there because वरना seafood या sushi का history होता, right? Gram negative rods are mentioned. Okay, bacilli rods meaning the same thing. Simple. आगे move करें. ठीक है. Then abattoir worker developed cutaneous ulcer. There was a positive McFadden's reaction for the diagnosis of which organism? Again, very simple. Abattoir worker, cutaneous ulcer. They are trying to tell you something about an eschar. And McFadden's reaction is for that capsule of which organism? Bacillus anthracis. So again, curved rods was given. ठीक है, यहाँ पे curve कर देते हैं at. नोकार्डिया भी था, ठीक है, इसकी जगह नोकार्डिया भी होगा, ठीक है, दैट इज फाइन. द आंसर इज गोइंग टू बी बैसिलस एंथ्रासिस. वेरी सिंपल. अगेन वी हैव आल्सो डन दिस इन द क्लास. Okay, moving forward, patient presented with brain abscess. This was a little bit a tricky question for me, but I just want you to confirm this, that there was a person who was having brain abscess with parieto-occipital lesion, and then there was some gram-positive filamentous bacteria with a positive modified Zdenstein and a paraffin-based technique. Right? What is the likely organism causing this? It wasn't blood, but FNAC. FNAC, okay. In which one are you saying it was FNAC? Bacillus anthracis वाले में there was nocardia, no. ठीक है. Staph milk product में, yes, staph is there, but they had given gram negative ना, तो milk product में then we can't do staph. Neisseria was in the option for this. Okay, there was, let's say Neisseria was there, but again, the answer here is going to be your nocardia. Modified acid fast, filamentous, paraffin bait, everything is pointing towards nocardia. Branched filamentous, ठीक है, branched भी होगा, then also it is fine. Answer is nocardia. Acid fast था, कोई बात नहीं, modified नहीं भी था, and even if it was acid fast, then also it is meaning the same thing. Zdenstein नहीं था, acid fast लिखा था, meaning the same thing. No problem, still. Okay, then there was another question that the best PCR method to use in the diagnosis of organisms causing meningitis. So here they are trying to tell you the whole syndrome that is causing meningitis. All the organisms ka causing meningitis, I told you multiple organisms, answer is going to be the multiplex PCR. ठीक है? Nocardia answer हो गया. Mycobacterium species option was not TB. कोई बात नहीं, Mycobacterium species कर देते हैं, that is okay. यहाँ पे multiplex PCR, it's going to be the answer. ठीक है? Nested PCR is not the answer because they're not asking you for a specific organism. They are saying multiple syndromes, all of them causing meningitis. So it was going to be multiplex PCR. ठीक है? Then I think there was another question that a patient was brought dead to the emergency department with meningitis was given. Postmortem of the brain was given. And there was some kind of a petechia in the brain. And thrombosed vessels were there. What is the most likely organism? Somebody said there was a clinical picture, and then somebody said there was some kind of a brain image with this. Multiplex PCR was not given. Are you sure? Because I got a lot of people telling me that it is multiplex PCR was one of the options. Was it or was it not? Yeah, था ना? तो हाँ, तो yes, this is going to be. Cryptococcus was given in the option. Okay, Cryptococcus was given in the option. So this, according to me, there was a clinical picture with thrombosed veins and petechia is what they were saying. Petechia bhi likha tha. So for that, for me, it is going to be Neisseria. Okay, multiplex tha. Very good, very good, very good. Moving on to the next question. We have moved on. Pneumonia and meningitis both were there around blood. There was one option of Cryptococcus. Pneumonia bhi tha, meningitis bhi tha. Okay. Pneumonia bhi tha, meningitis bhi tha. And there was image of the brain. Neisseria was the answer. Yes, because if there were multiple, this is your meningococcemia. Meningococcemia tha, and Neisseria ka, these are your disseminated Neisseria. So this is your disseminated Neisseria causing hemorrhage. So this is going to be Neisseria meningitis for me. Hypotension tha question mein. Okay, I'm going to frame this better. Hypotension tha, I'll frame it better. Okay, moving forward. Child presented with pharyngitis. There was some group A streptococcal, which was isolated from the throat specimen, and you were asking the factor that was helping the fibronectin in this organism to attach. So group A streptococcus meaning streptococcus pyogenes. Streptococcus pyogenes meaning it is a gram-positive cocci. Gram-positive organisms contain something specific, which is going to be your lipotecoic acid. Lipotecoic acid was something that was helping with the addition. Remember, inhibiting the opsonization, inhibiting all the other things, and then helping in the addition. ठीक है? Okay. ठीक है, तो lipotecoic acid हो गया. Then we had a patient who had a trigeminal neuralgia. Okay, people are saying capsule. Streptococcus pyogenes is not capsulated. It is not capsulated, so hence that is not the answer. Lipotecoic acid and the tecoic acid, two of them that were helping in the addition. Gram-positive cocci, gram-positive का bacterial cell wall जाकर देखना. A patient that was having trigeminal neuralgia with perioral vesicular lesions, giant smear showed multinucleated giant cells, intranuclear inclusion body. ये तो बिल्कुल simple था. That was going to be your herpes simplex virus. And a multinucleated giant cells, rank smear, trigeminal neuralgia, everything was going to be pointing towards herpes simplex virus infection. Okay, vesicular lesions, very simple. Okay, another question was there on a patient that presented with recurrent arthralgia, urethral discharge, CNS symptoms, and diagnosis was Neisseria gonorrhoeae. They had kind of made the diagnosis and investigation most appropriate for the underlying immunodeficiency. So they're talking about the recurrent or disseminated Neisseria again, right? And MAC deficiency हमने पढ़ा था, membrane attack complex deficiency is the one that leads to this kind of a thing. Streptococcus pyogenes is not capsulated. It is not capsulated. Hence, capsule firstly does not totally help in addition. Secondly, capsule is anti-opsonization. It is not something that will lead to proper addition. Addition के लिए lipotecoic acid है. CMV was in the option, ठीक है, तो CMV डाल देते हैं, but answer was going to be your herpes simplex virus. Here, then again, okay, 19-year-old boy वाला था, 19-year-old boy repeated gonococcal infection, ठीक है. Simple answer is कि it is going to be the disseminated or recurrent infections due to the late complement. Okay, late complement लिखा था, that is fine. Late complement meaning that it is C5 to C9, that is going to be your MAC deficiency, है ना? Okay. Anything else? Can you just tell me, was there another question that was mycetoma, diagnosis of a filamentous fungi? Was there a question on mycetoma was the answer? Was it anything related to that, or it was going to be the same one जो हमने बात करी है अभी, or was it a different one? Okay, IgA deficiency था. Thank you for that. What is this? Was there a separate question for the filamentous wala? Or was it the same one? Can anybody help me with that? Can anyone help me with that? Same. ठीक है. Okay, same question. Okay, SCID का ADA deficiency was there. Okay, there was absence of B and T cells and the NK cells. Okay, they had given ADA deficiency. ठीक है, ADA deficiency दे दिया, absence of B T cells combined SCID हो गया. Severe combined immunodeficiency disorder, है ना? SCID was there. So yes, that is the answer. Okay, so I think that is all from my side. Thank you, everybody. If you have any more questions, then please message or DM me. I think after me, Reena ma'am is there. Okay,
Yes,
Reena ma'am is
I
going
am
to
there.
take over.
I am there.
Okay.
Okay, so hi everybody, just let me share screen. Okay, so gynae was, I think, very easy and straightforward, but let us discuss to just so that we're all on the same page and there are no doubts. There was a question on assisted breech delivery. What was this maneuver? If this was the maneuver asked, as shown in the image, then this is the Lovset maneuver. All right, so nuchal arms, when they're there, removing the arms, this is called Lovset maneuver. The next question was a question on cord prolapse, and they asked what is the best thing to do. The baby is still alive. When the baby is still alive, because the cord is still pulsating, you have to shift to the OT, and while shifting, try to relieve pressure off the cord. So this would have been the best option. Trendelenburg, push the head up, fill the bladder, shift to OT. The next question was a question that there was a delivery by a dye, I think, and the patient had a prolapse and some image was given of a prolapse, and they asked a question that was which ligament is weakened that leads to prolapse, and the answer, the best option amongst the answers was Macken-Rods. These aren't supports of the uterus. Macken-Rod, uterosacrals, these are the ligaments which support the uterus. Okay. So if there are any changes or anything you want to add or subtract in the recalls, please let me know on YouTube, which I am looking at simultaneously. One question on eclampsia, preeclampsia always comes. This time they asked Pritchard's regime. The total loading dose of magnesium sulfate is 14 grams. We give 4 grams IV plus 10 grams IM. So total loading dose of 14 grams. Okay, sacrospinous was the option here. So I'll just add that. And yeah, it was a delivery by a thigh. Okay. Then there was a question, there was several questions on postmenopausal bleeding and increased ET. So this is what I have. There was a 46-year-old woman with 16 millimeter endometrial thickness on TVS. So whenever the endometrial thickness is more in a woman in the reproductive age group, you have to do an endometrial biopsy. You can't directly do a hysterectomy, or next best step is to do an endometrial biopsy. Then there was an easy question on layer suture and episiotomy. How do we suture it from inside out? We go mucosa, muscle, and then skin. Okay, broad ligament was also there. All right, fine. Okay, a hysterectomy was done for postmenopausal bleeding. There was an image which looked like this. What I was told is there was some dirty looking growth within the uterus, something similar to this. So when there's postmenopausal bleeding, okay, and growth inside the endometrium, this is most likely endometrial cancer, fibroid adenomyosis, endometriosis. Endometriosis definitely will not present with postmenopausal bleeding. Even these two are unlikely to present. Fibroid will be a more well circumscribed lesion, again unlikely to present as postmenopausal bleeding. So this was endometrial cancer. Okay, there's a question again on postmenopausal bleeding. She had blood-stained vaginal discharge. Her blood pressure was 170 by 100. So that's there, but that's not the first thing you will do. She needs, her blood pressure has to be brought down, but she's come to you with this with blood-stained discharge. We have to evaluate her for postmenopausal bleeding, do a pelvic examination, put in a speculum, take a pap smear, and do a TVS to look at the endometrial thickness. So this would have been the best answer. I don't know what the fourth option was. If you could add it, it would be good. Okay, then there was a question of previous LSCS in labor. She was 8 centimeters dilated, head at -1, but there is now maternal tachycardia and fetal bradycardia. And in between contractions, she's having suprapubic pain. Most likely that's the scar which is about to give way. This is a typical presentation of scar dehiscence or incomplete rupture. You don't want her to rupture, so immediately do a cesarean section. Okay. Identify the maneuver. There was something given like this. This is controlled cord traction or modified Brandt-Andrews technique. One hand on the cord, one hand pushing the uterus up. This is controlled cord traction. Okay, she came for routine blood pressure, Naman. Okay, thank you. I'll add that. Okay. 5 centimeter वाला शायद से cord prolapse question था. ये वाला 8 centimeter था, है ना, previous LSCS वाला. Okay, all primary measures in the medical management of atonic PPH has failed. So a patient scenario was given where patient had atonic PPH and all primary measures had failed. And the question which many students are telling me कि specifically पूछा था कि labor room में क्या करोगे? What will you do in the labor room? Is you will do mechanical measures, because this is the next step. Medical and mechanical go hand in hand. And then if these fail, then is when you consider referring the patient or shifting the patient to the OT. So if it was specifically asked in the labor room, then intrauterine balloon tamponade is the correct answer. Then there was a question on secondary amenorrhea, and values of FSH, LH were given, which were high. AMH was given, which was very, very low. Normal AMH is between 1 to 6. So this is premature ovarian failure or premature menopause. Menopause which happens before 40. Typically, FSH is going to be high. Estradiol is going to be low. AMH is also going to be very, very low. Okay, a P2, L2 was bimanual massage given, Avneet, in the question. Bimanual massage tha. I don't think it was there in the options, but mechanical methods go together, and even amongst this and this, we would prefer tamponade because medical management has failed. Kab tak massage karte rahoge, you have to put in a tamponade. Okay, then there was a question on prevention of venous thromboembolism in the puerperium. Remember, the drug of choice is low molecular weight heparin. I don't think there's any confusion in this. Okay, so drug of choice for prevention of VT, both in pregnancy and the puerperium, both is low molecular weight heparin. A pregnant lady in first trimester pregnancy with a history of toxoplasmosis 5 years back, IgG positive. Remember, I've always told you this IgG ka matlab hai ki old infection, not recent infection. And so here the best thing would be she's safe to continue pregnancy. If IgM was positive, then you have to evaluate further. Okay. Next, a 30-year-old woman with GDM is in labor. The head delivers, but the shoulders get stuck. So this is your helper mnemonic. And in the helper mnemonic, we know that the sequence of things would be Mac Roberts in what is given. If these were the option given, so call for help, episiotomy, legs, that is Mac Roberts, suprapubic pressure, these are your first line. Then enter the rotational maneuvers, Rubin and Wood corkscrew. Remove the posterior arm, roll on all fours, that is Gaskin. And then these are the second line. And then third line are Zavanelli, symphysiotomy, or cleidotomy. These are your third line maneuvers. So this is a straightforward question. Okay. So in the PPH question, if the question was labor room में ही है patient अभी तो tamponade करना है. If the question was all measures have been done, now what to do? When it says all primary measures, it usually includes medical and mechanical. Then what to be done? Then you shift the patient to OT for surgical. So if this line was there, what next in the labor room? Then it is clear cut balloon tamponade. There was a question on cervical cancer staging with bilateral hydroureteronephrosis. Straight away, this becomes stage 3B. All right. This was also quite easy. Then there was a question, and I need to understand this better. Ki kaun sa image diya tha? There was a question where patient had, I don't know, her age or her parity that may play an important role. She had abdominal discomfort and chronic abdominal pain. Now, if the image was something like this, diffuse uterine enlargement, this is the endometrial thickness with these speckled things inside, then it is more likely to be adenomyosis. But if it was a well circumscribed lesion like this causing uterine enlargement, then it is more likely to be a fibroid. Also, adenomyosis will happen in the age group of above 40. This is usual. Of course, you can have exceptions. And adenomyosis is more common in a Paris woman. Fibroid will be more common it can happen anywhere between 30 to 50. So 40 पे भी हो सकता है fibroid, है ना? But usually it will be nulliparous or low parity. Okay, so it depends. I don't know what the image came. I don't know what the answer is. It depends. If this image, then definitely adenomyosis. This is definitely fibroid. Take a first image came, then it is adenomyosis. Okay, first one is adenomyosis. It's not a well circumscribed lesion. You can make out it's diffuse enlargement, hai na? Whereas here it's a very, very well circumscribed lesion. Okay. Lymphadenopathy was present after toxoplasmosis. Still, IgG is positive. That means it's a Purana infection. It is not going to affect the fetus right now. Lymphadenopathy was given to confuse you. Okay, then there was a question, an ovarian cyst was given, and CA125 was given in thousands, and this would be serous cyst adenocarcinoma. Again, I think ascites was also mentioned in this question. Adenomyosis था age 40 plus, fine. ठीक है, no bleeding है ना, so pain. Fibroid will usually cause heavy bleeding. Adenomyosis will cause abdominal pain, and this patient had discomfort and pain. Okay, cord prolapse में बच्चे, you have to shift to OT, and while shifting to OT, you have to reduce the pressure of the cord. ET was marked on the image. Yes, that someone told me. So this is the endometrium. Okay, next question. Prolactin will cause amenorrhea. So this is, I think, actually a physiology or a medicine question, but put it here also. Prolactin, hyperprolactinemia causes amenorrhea. It is a common cause of secondary amenorrhea because it decreases GnRH, and this results in secondary amenorrhea. Okay, I think some other options with this: increase LH surge, down regulation of estrogen receptors. I don't know the fourth option, so let me know if you can remember. Okay. A patient presents with amenorrhea. On examination, there is linea nigra, bluish hue. So this was a little confusing question. On vaginal examination and prominent Montgomery's tubercles. और कुछ दिया हुआ था इसमें. What signs of pregnancy are these? Okay, so if these are there, okay, and these are your presumptive signs of pregnancy. Okay, presumptive signs are all the symptoms: nausea, vomiting, fatigue, weakness, breast tenderness, amenorrhea. Okay, along with that, few signs come under presumptive. That is skin discoloration. So linea nigra comes under there. Bluish hue, Chadwick sign, comes under both presumptive and probable signs. Okay, and all the other signs means uterine enlargement, or you have the external ballotment, internal ballotment, all the other Goodell sign, Hagar sign, all come under probable signs. So the initial signs are presumptive. Okay, then we have probable, and then we have confirmatory. Confirmatory is of course ultrasound, है ना? Even fetal heart rate comes under confirmatory. So this is most likely from what is given should come under presumptive. Okay, but I'm not sure about this because some people telling me कि uterine enlargement भी दिया हुआ था. अगर uterine enlargement भी दिया हुआ था तो probable भी आ सकता है ना? So just let me know what, if any other thing was given, then accordingly, because uterine enlargement दिया हुआ था. Okay, uterine enlargement was also given. That would be a probable sign then. So this was a little tricky. Okay, if uterine enlargement was given, मतलब presumptive भी थे और probable भी हो गया, possibly probable. But I need to know an exact recall to help you all better. ठीक है? Okay, a woman presents for routine checkup. She has 28-day cycle. On day 21, 25, what are the hormone levels? So this was easy. Physiology में भी cover हो गया है. What's going to happen? Estrogen, progesterone are going to be high. FSH, LH are going to be low. Repeat question from physiology. Okay, woman does not remember her LMP. She's come to the antenatal OPD. CRL is the best way for dating the pregnancy. Okay, if presumptive option ही नहीं था तो it becomes very easy ना, तो फिर तो probable ही हुआ. Okay, so if uterine enlargement was there, again, there's a lot of confusion in this question. Don't break your head over it, to be very honest. If uterine enlargement was there, what I would have marked probable. But अगर ये नहीं दिया था, तो I would have marked presumptive. Okay, so I hope that clears your doubt. Easy question. The umbilical cord contains 2 umbilical arteries and 1 umbilical vein. Okay, and this was also quite simple, straightforward. Another last, I think it's the last question. NST is being done for a patient who has decreased fetal movements. The NST shows 1 acceleration in 20 minutes. There are no decelerations. What is the next best step? So whenever you have this kind of picture where it's not a reactive NST, you need to have 2 accelerations. So what do? The baby might be in a sleep cycle. So you have to continue the NST for 20 more minutes. So total of 40 minutes you have to do the NST. And if still it remains the same, then the next step would be to do a biophysical profile. So there's no doing an emergency cesarean or induction of labor based on just absence of accelerations. Okay, so this is what is important. And I hope this was helpful. Okay, if anything I've left behind, please mark or let me know. And okay, wait and observe was an option. Got it. All right. So thank you. All the best for the result, and do let me know if I've missed anything. I think Dr. Anand is next.
No, ma'am, I'm doing.
Okay. Hi, Dr. Dilip.
Hi, ma'am.
Okay. All over to you.
Thank you. Hi, guys. I hope you can see and hear me. And how was the exams? You guys did well? I hope you all did. Yeah, so I'm able to see the comment. Just hold on. Let me share the screen. All right. So I'm going to share my screen. Yeah, I think now you're able to see my screen. All right. Sorry, I couldn't prepare a PPT because I was pretty much busy today and I have a lot of patients to see from now on. So let me finish it off faster. I think this is an easy question. This is something that we have discussed already so many times in our classes. A patient with diabetic ketoacidosis is presenting with very high sugars. So this must be a pseudo hyponatremia. We're going to use everything except 3% NaCl, right? Any doubts in this question? I think this is a case of DK. And we're not going to use 3% NaCl, right? So that's an easy one. So this is the patient who's having chronic kidney disease, right? Presenting with anemia. So if they've not mentioned anything with regards to iron deficiency, so I will go for darbepoetin alpha, which is an erythroid stimulating agent. Okay, so that's going to be the best treatment in this situation. But if they have mentioned about iron deficiency, then probably you would have gone for oral iron or parenteral iron. But I don't think they have mentioned anything about the iron deficiency, so better to get for darbepoetin alpha. So this is a case of scleroderma with anti-SCL70 antibody. I think we have discussed this so many times in our classes. Anti-centromeric antibody correlates with Gress syndrome, and especially pulmonary hypertension, and anti-SCL70 antibodies tend to correlate with something called as ILD, that is interstitial lung disease. That's it. So coming to this one, so this is a case of Sjogren syndrome because patient is having all the Zika symptoms and patient's Schimmer test is positive and patient's anti-Ro antibody is positive. So 100% this is a Sjogren syndrome. And I think the first thing that I used to tell in the slides when I discuss about Sjogren syndrome is about the lymphocytic infiltration, especially the CD4 lymphocytic infiltration of the lacrimal and the salivary glands. All right. So if you look at this question, so I think this is a child. It's not a 62-year-old woman. So it's a child, maybe 10 years, 8 years. Some X-ray changes are also given, but the child has CKD for sure. And calcium was low. Normal calcium is 9 to 11. The patient's having hypocalcemia. Phosphorus is 6.7, pretty much higher. And, you know, it's a renal osteodystrophy. So PTH is high and alkaline phosphatase was high as well. So asking what you're going to do next. So right answer for this question is going to be calcitriol with calcium supplements. You might argue with me that are you going to give calcium and phosphate binders? Yes, phosphorus is high. They're asking about the next step in the management. So I don't really go for calcium and phosphorus binders alone. I don't think so because most of the time when it comes to practice, the CKD patient, we're going to use calcium supplements and calcitriol. I don't think without calcitriol, you're going to absorb calcium supplements. And if you're going to give only calcium and phosphate binders, it can even increase the risk of vascular calcification, and that's not going to be appropriate. The first line treatment for most patients is going to be calcitriol with calcium supplements. Try to put down your PTH. Your PTH levels are going to come down, and that is probably going to reduce your phosphorus levels to some extent as well. So, but technically speaking, it's going to be the calcium with calcitriol. That's the baseline treatment in CKD patients. At top of that, only are going to build up with phosphate binders. I don't think straight away, going to phosphate binders is going to be of any use. So coming to this one, so this is an easy one. So I think the patient is positive for anti-CCP. So this must be a rheumatoid arthritis. So of course, what you're going to see is the classic Panus formation, easy one. So this is a case of pseudogout. You can see positively birefringent rhomboid-shaped crystals. So easy one. So this must be pseudogout. All right, this must be pseudogout. Now, coming to this one, so this is something that we have discussed so many times in our classes as well. This is a case of ankylosing spondylitis. You can see a 27-year-old young chap presenting with low back pain, with stiffness, anterior uveitis, typical ankylosing spondylitis. X-ray of the sacroiliac joint is normal. So the next step is going to be to do MRI of the sacroiliac joints. And coming to this one, so they're asking about the prophylaxis of PSVT. I think we have discussed this also in the classes. It's going to be an AV nodal blocker, like a beta blocker or probably a calcium channel blocker. But you know, IV esmolol is actually a beta blocker, but why you want to use an intravenous drug for a long-term prophylaxis? That doesn't make any sense. So we're going to go for oral diltiazem. That's it. Sixth question was not there. I think it was there. I think a lot of students told that the Panus formation question was there. Look at this one. I think there were 4 questions on atrial fibrillation. This was one of the first questions on atrial fibrillation. Patient came with sudden onset weakness, aphasia for 2 hours. The patient is in window period. Patient is having atrial fibrillation. That really doesn't matter. What they mentioned is the fact that CT head is normal. This is what is the most important. We have ruled out hemorrhage. Patient is within window period. No contraindications for thrombolysis. Straight away go for TPA, that is alteplase or tenecteplase problem. So that's going to be the right answer. Easy one. Look at this one. I think this is a case of acromegaly where you want to find out the most specific confirmatory test. So it must be growth hormone that is not suppressed by OGTT or probably growth hormone suppression by OGTT. So that is going to be the confirmatory test, not the IGF-1 suppression. Nobody gonna use IGF-1 after OGTT. It's going to be growth hormone suppression by OGTT. That's the most important. So this is an interesting question. I think people might have varied opinions on this. Patient collapses, breathless, pink frothy sputum suggesting pulmonary edema. Autopsy showing hemosiderin ladder macrophages. In which condition this is not seen? That's what they're asking. I believe that, it must be a right heart failure. It's a simple one. In an isolated right heart failure, do you really think patient is going to have pulmonary congestion in the first place? So in a patient with isolated right heart failure, you might have jugular venous distension, you might have hepatomegaly, you might have something else, but I don't really think that you're going to get pulmonary congestion in isolated right heart failure. So this is a classic kind of a question in most of the entrance exams. So what they tend to do is they tend to pick up a list of causes from the standard textbooks and they just change certain things in the question. Like probably in the textbook, they would have seen left heart failure. So it's just changed into a right heart failure. So just made it as like, which of the following is not seen. So I feel like from the examiner's point of view, it's a classic question. You can see that it must be right heart failure. As simple as that. Technically, that does not produce any pink frothy sputum. You cannot get a pulmonary edema in patients with right heart failure. According to me at least, it's not possible. That's also the reason why in pulmonary embolism you get a clear chest, in tamponade you get a clear chest. In right heart fails, how can you get a pulmonary edema? It's not possible. So all other conditions you can get pulmonary edema. Okay, all right. I think this is an old man with increased head size. All right, so that is the clue here. Everything normal except for raised alkaline phosphatase. So many times we have discussed this is classic Paget's disease. Absolutely no doubt about that. And coming to the next question, patient is diabetic, already on insulin metformin. He's also having symptoms and signs of heart failure. So what is the next best drug to be added? Of course, it's going to be SGLT2. We predicted this question long time ago. So this must be empagliflozin without a doubt. Again, another atrial fibrillation question, easy one. Patient is having irregular pulse, meaning that the patient is having atrial fibrillation and you cannot get a presystolic accentuation in AFib. I've already been teaching about the 4 no's in atrial fibrillation. What are the 4 no's? You don't have a P wave in the ECG. You don't have an A wave in the JVP. Third one, you're not going to have S4. You cannot get S4 because S4 is also due to atrial contraction that's going to be absent in atrial fibrillation. Last but not the least, no presystolic accentuation in mitral stenosis. These are the 4 no's in atrial fibrillation we have been discussing time and again so many times. So the answer is going to be D for this question. As simple as that. So this patient has a hyponatremia. I think the values were given. I think it was around 95, something like that. And now it has jumped to 115, something like that. And they're asking like patient developed quadriparesis or probably bulbar palsy, meaning this patient is having osmotic demyelination syndrome, previously called as central pontine myelinolysis. So you're going to do an MRI brain to find out what's going on. So it's very sensitive investigation. So don't forget about raised JVP. People are always talking about raised JVP. Don't you really think, guys, raised JVP is there? The question is whether the patient can have pulmonary edema or not. That's what the question is. They're asking which of the following is not seen. So the question was not about whether you're having a raised JVP or not. Question was about that hemosiderin ladder macrophages, pink frothy sputum. So I always tell this to the students, please don't go for the right answer in exam. Always try to select the best answer in the exam. I always tend to tell that. So it's not about the right answer. Forget the right answer in exam. It's always about what you choose the best. Because in exam, that's how it works. Right? So coming to this one, this is a very tricky question. So chlorthalidone, okay? So that's a thiazide diuretic that's going to reduce like calcium excretion in the urine and develops renal stones. I don't know whether this was the real question or not, but it's a very tricky question. I believe like increased calcium excretion is one of the reasons for stone development, all right? But in the presence of chlorthalidone, you're not going to get that. You're going to have lower calcium excretion in the urine. And urate, decreased excretion is going to reduce the risk of stones. Increased phosphate reabsorption has nothing to do with the stones. So you all know that there are only 2 mechanisms of stone formation in the urine, right? So one is going to be increased calcium, or second is going to be reduced citrate. The urinary citrate is going to be extremely important, technically speaking. So that's going to chelate the calcium. So in case if the patient is on chlorthalidone and you cannot get increased urinary calcium, your citrate, because if it's going to be low, you're going to result in like free calcium and that can produce stones. So according to me, at least, it must be citrate. It must be citrate. There's nothing else. Right? There are only two reasons. Or it must be due to increased oxalate excretion, something like that. So was there an option called increased oxalate excretion? So if it's increased oxalate absorption from the kidneys, that cannot result in stones, isn't it? Okay, so this is increased oxalate reabsorption. So that cannot lead to stones, right? So oxalate in the urine is going to produce stones. Okay, so I believe this must be the right answer. Do you guys agree with me? So decreased citrate excretion. So that's a very common thing that we see in practice. That's why when you do a 24-hour urine analysis in a patient with stone, you check for calcium, you check for oxalate, and you check for citrate. These are three things we check apart from the urinary pH. Okay, decreased calcium excretion was given. Okay, so that cannot be the reason for stone formation. Okay. Not chlorthalidone, it's hydrochlorothiazide. It doesn't really matter. So both are thiazide diuretics anyways. Okay, two citrate options were there. Two citrate, right? So decrease citrate, increase citrate. Two citrate options were there. Because it's a tricky question, I'm just taking a bit of time. Sorry for that. Yeah, I changed it. Decreased calcium excretion, decreased urate excretion, increased oxalate like you guys suggested, and decreased citrate excretion. Okay, so if citrate is there, that's going to be the right answer. Let us move on to the next question. I'll discuss in the group the other things. Okay, so there was another question on atrial fibrillation. So patient is having atrial fibrillation and patient is having aphasia or weakness, something like that. So they're asking, what is the next step? So to find out clot, so how do you find out clot? The best investigation is going to be the esophageal echo, right? The carotid Doppler is for patients who don't have atrial fibrillation. I don't think that's the right answer. Transthoracic echo is going to miss out the clots in the left atrium because it's not sensitive. MRI is not going to be useful in this situation. So the best answer is going to be the transesophageal echocardiogram to find out clot in the left atrium. If this was the question, so that's going to be the right answer. So coming to this one, 20-year, yeah, this easy one. There's a case of Marfan syndrome. So the likely defective gene is going to be the fibrillin 1. Okay, so this was a case of achalasia. I think it's a simple case. I mean, let's not complicate this. So patient is having difficulty in swallowing, dysphagia, regurgitation, weight loss. The classic triad of achalasia is there. Perineum swallow is showing the bird beak appearance. The best investigation to confirm the diagnosis is going to be the esophageal manometry. Okay, there was another option of CT angiography here. Okay, all right, but still the thing is not going to change. It's going to be transesophageal echo. Yeah, let us change. I mean, instead of what, you have CT angiography here. Instead of what, you have CT angiography, by the way. So either transthoracic echo or carotid Doppler, or instead of what, CT angiography. Okay, so that was a different question, pulmonary embolism. In that CT pulmonary angiogram was there. I mean, let's move on. So you're confusing with another question. Okay, I think this is an easy one. Patient is having a history of premature coronary artery disease and episodic migraine, and which is going to be the long-term prophylactic agent for migraine. It's going to be propranolol, no doubt, easy one. So that's what I'm going to use. Other drugs are not going to be helpful. They asked about the mechanism of action of benralizumab. I think we have discussed all these things in our pulmonary medicine and critical care, where I told you it's going to act against the interleukin-5 receptor. So you have three drugs that act against the IL-5. So one is going to be your mepolizumab, second is going to be the benralizumab, and third one is going to be the reslizumab. These are the three drugs that they have asked about benralizumab. Happy for you guys. All of you have got it right. So they've asked about another drug in GRD that's going to reduce, I mean, not reduce, it increases the LES tone and as well as the gastric motility. So which means it's a prokinetic drug. The right answer must be metoclopramide. Easy one. And coming to the prophylactic drug, prophylaxis of Neisseria meningitidis, right? Prophylaxis of Neisseria meningitidis. So there are three options. Either you can give rifampicin 600 milligram 2 times a day for 2 days, or you can give ceftriaxone single dose 250 milligram IM, or you can give ciprofloxacin 500 milligram stat. You have three options. So you don't have ciprofloxacin here, you don't have ceftriaxone here, so it's better to go for rifampicin. As simple as that. So HIV patient, as I think we have discussed this, easy ones, HIV patients always are prone for iris. That is what you need to look for. I think even in the GTs we have discussed so many times. And this is amiodarone's phase 3 repolarization, simple. And yes, this is something that we have discussed in our respiratory medicine. Every now and then, a patient who is an asthmatic is supposed to be on LABA and ICS. This is going to be the best treatment ever. We have discussed that so many times. And this is also something that we have discussed in the HIV discussion. If you have listened to my lectures, I've told you how to approach this case. If the viral load is less than 1,000, viral load is more than 1,000. And also how to approach whether the patient is going to go for exclusive residual feeding or exclusive replacement feeding or exclusive breastfeeding. So because they have talked about exclusive breastfeeding here, it's going to be a combination of zidovudin and nevirapine for 12 weeks. That's very, very important. So plan for surgery, phenoxybenzamine, we know that it's for BP control. So I think they have asked about the BP control. So 100% it is phenoxybenzamine, no doubt. So I think this is a case of varicose veins. And yes, lipodermatosis and eczema can occur. This is also something that we have discussed in our classes. And this is an easy one. MCHC was increased. MCHC was increased. That's a clue here. And patients having family history of jaundice, splenomegaly. So simple clue, answer must be hereditary spherocytosis. I'll come up with where we have discussed in the classes later on, but not right now. So look at this one. So this is a case of, a simple ABG case. I think they have asked you to find out the anion gap. It's around 30, I guess, if I'm not wrong. So yes, it must be somewhere around 30. They've asked about something with regards to a COPD patient or something like acidosis. If I'm not wrong, so there was a question in this. Acidosis, right? There was a question on respiratory acidosis, isn't it? Okay, base deficit of 12 is given. Okay, I'm not sure about that. So I think they have asked a simple question, something like respiratory acidosis, nothing more than that. And so this is to prevent postpartum venous thromboembolism. So answer is going to be low molecular apparent. So in any post-surgical period, so perioperative period, we're going to use low molecular apparent. There's no doubt about that. And what about this one? I think this is the case that people were talking about. So patient had a right total knee replacement or some knee surgery like 2 to 3 days ago, now presenting with breathlessness, tachycardia. So this is actually a case of pulmonary embolism, right? This is pulmonary embolism. So for this, answer must be CT pulmonary angiogram. Look at this question, easy one. So they're asking about the mechanical ventilator strategy for ARDS. It must be high PEEP and low tidal volume. It's a very easy one. I don't think this needs any further discussion. And this is the same image that we have discussed in the classes as well. This must be meningioma. Again, without an iota of doubt, as simple as that. Let's look at this one. So this patient is having primary biliary cholangitis. I don't know exact question they asked, whether they gave the antibody and they've asked the diagnosis, or they gave the diagnosis or they asked the antibody. I'm not worried about that. So I think something with regards to this is there. So whether AMA has been given and they've asked the diagnosis, or they've given the diagnosis and they've asked about the antibody. So whatever may be the case, in either way, it's going to be easy one. So this is basically a case of diffuse axonal injury, easy one, because they have told about this petechial hemorrhages at the gray-white junction, so especially near the corpus callosum. So that must be suggestive of a diffuse axonal injury. Look at this one. This is a simple case of LMN. So out of this, this is actually a UMN. This is also a UMN. This is also a UMN. The only thing that I can put under LMN is this one, because the patient's deep tendon reflexes are absent and patient is having atrophy. All these are features of LMN, so it has to be anterior horn cells, because all other options actually correspond to UMN lesion, not LMN lesion. So this is an easy one. Even in a GT, we have made like 2 to 3 questions on this. So this is basically based on Kurvaisius law. Simple one, carcinoma head of pancreas, painless jaundice, palpable gallbladder is almost always due to cancer unless proved otherwise. That too in an old person like this. definitely have to think in terms of cancer. So the moment you see terminal ileal resection, one of the commonest problems that you're going to encounter is B12 deficiency. Easy one, not very difficult at all, because ileum is responsible for B12 absorption. So I think this is about high altitude. We have discussed that so many times. In high altitude, you're going to get respiratory alkalosis because of fast breathing. Done. And I think which is responsible for hyperpigmentation was the question. In patients with Addison disease, it must be ACTH that must be responsible for hyperpigmentation. And this is a case of AML M3, if I'm not wrong, that is acute promyelocytic leukemia. So they've given cells with oil rods, and they've given coagulopathy, some bleeding tendency. I'm not sure exactly what was the question, but there was a history of some coagulopathy and bleeding tendency that was given, which is suggestive of disseminated intravascular coagulation. So it must be PML RARA fusion, that is T1517. That's APL. And it's about follicular lymphoma. You can see CD10 is positive, meaning that it's coming from the germinal center, and BCL2 is overexpressed, T1418 translocation, follicular lymphoma. And which is going to get corrected? Which coagulopathy is going to get corrected with vitamin K? Very simple. It's going to be due to vitamin K deficiency. What's going to produce vitamin K deficiency? Most of the time, it's going to be cholestasis. So it's going to be bile duct obstruction. Okay, so this is basically a neuroleptic malignant syndrome. For that, we're going to administer dantrolene. We have discussed that in critical care. Yeah, all of these things we have discussed in marathon as well. Everything, every single of them we have discussed already. No doubt about that. And this is also something that we have discussed in marathon, and the medicine a day, in the QR every time. So this is an easy one. So this patient is having thiamine deficiency. Because of that, patient is having heart failure, peripheral neuropathy, and they're also prone for Wernicke-Korsakoff problems as well. This is adenosine deaminase deficiency. We have discussed this in rheumatology. So about primary immunodeficiencies, we have discussed in detail. So this must be a SCID. The two gene defects that we have discussed when it comes to the primary immunodeficiencies that can cause SCID. One is ADA, remaining you can tell by yourself. So this is also something that we have been discussing so many times in HIV, so that we have to start with ATT first and then ART. So we have to give a delay of at least 2 weeks. And meningococcal infections are very common in terminal complement deficiencies. That's the reason why drugs like eculizumab has a high risk of meningococcal septicemia. We have discussed that in rheumatology again, and even in hematology. I told you, before giving eculizumab, meningococcal vaccines are a must. So this is on how to find out CD molecules. So we have discussed that in hematology. Flow cytometry is simple, easy. I think even in the GET, we have got one question on like sewage work in India. Whenever they mention that conjunctival suffusion, it's always almost going to be leptospirosis and Weil's disease. And this is about a condition called as osmotic demyelination syndrome. I think it's a repeat. Sorry for that. So answer is going to be MRI. And this is again a question on atrial fibrillation, where they've asked about what to do first. It's always about the rate control. So just go for rate control first. That's going to be verapamil. So it's about administering intravenous fluids, and patient has developed hyperchloremic metabolic acidosis. I told you only 3 questions. Only 3 things are there. That's going to produce NAGMA, that is normal and gap metabolic acidosis. One is going to be diarrhea. Second is RTA. Third is going to be saline. Saline means we're talking about the normal saline, which is one of the most commonest causes of hyperchloremic metabolic acidosis in hospitalized patients. So answer is going to be normal saline. So I think there was another question on Addison disease, where the patient had salt craving, generalized hyperpigmentation, hyperkalemia, and metabolic acidosis. So it's a straightforward one. It's Addison disease. It's an easy one. There's nothing more to discuss in this. And even in like pituitary, we discussed the first thing that we have discussed is prolactinoma. I've been keeping on telling this so many times that whenever you have a high prolactin in the body, it's going to suppress GnRH, and that's going to result in low FSH and LH, which is going to result in amenorrhea and infertility in women. So that's going to be decreased GnRH secretion. And there was a question on nocardia as well. So there was a brain abscess case, AFB positive, filamentous beaded appearance. So that must be nocardia brain abscess. I think for meningitis, you have to use something called as multiplex PCR. And this question was very controversial. The X-ray question, I'm not sure whether it was a collapse or whether it's a consolidation or whether it's a lung abscess. I was not very sure about that. So what they have, typically given in exam, like we have to reanalyze one more time. So because some students are telling it's lung abscess, some students are telling it's collapse, some students are telling it's consolidation. I'm not very much particular about that. Somebody is telling options are not accurate for this medicine session. I mean, you expect me to get an accurate options like within 3 hours of the exam? I don't think so. It's not possible. So I didn't prepare the questions. So NB said the questions. I mean, obviously we are discussing NB style questions. Technically, we are not really discussing the actual questions. Disclaimer, you all know that. I mean, even you have to keep saying the same NB style questions. Maybe for the next exam, we are discussing right now. So not something that has happened in the morning. Yeah, in case if you're going to have air bronchogram, yes, it goes more towards consolidation. Okay. So you have to look for those air bronchograms. Yes, if that is the case, like it's going to be consolidation. Tracheal shift, I mean, normally slightly towards the right is very common, right? So it's physiological. I mean, unless until there is a gross shift towards the right side, I'm not going to take it very seriously. A minimal shift towards the right side, yes, it's fine. All right. So I can even find more questions. I mean, hopefully you guys find out the questions quite easy and simple. I think medicine had around 60, 70 questions, if I'm not wrong. So you people might be calling it basic sciences. You people might be calling it something else, but I call it medicine because all these things is something that we have discussed in our classes every single time. And people who have attended the classes must be knowing about it. Isn't it? Okay, cool. All right. Thank you so much. See you guys. All the very best for your results. And like enjoy the next few days. I mean, don't get into a lot of tension. Looking for the results, looking for the recalls. This should be the last day looking for recalls. Like from tomorrow onwards, start enjoying your life and wait for the results. And you cannot change the results. Neither I am. And let's move on. Thank you. Bye-bye. Good night. Back to the next speaker. I think it's Shrikant Verma, sir, who's waiting. Sir, you're in mute, sir.
Yeah, thank you so much, sir. Thank you.
Welcome, sir. Welcome, sir.
Hello, dear students. Please inform me that all audio, video, everything is okay. So as I got the information, the anatomy questions are also easy to moderate level. Okay, so we are going to continue. I will not take the too much time. Yes, again, this is the disclaimer. It is based on the our recall basis. So wordings, the images, they may change. So please inform me, sir. Overall analysis, the anatomy question. I'm not telling about the integrated anatomy question. I am telling you 11 question. General anatomy. This time no question from the general anatomy. Head neck 2 question. Neuroanatomy 4 MCQs. Upper limb 1 MCQ. Lower limb 2 MCQ. Thorax, abdomen, pelvis. No question had been asked. And the embryology and histology. One question had been asked. Okay. Fine. Yes, dear students, all okay. Yes, buzzword section helpful. Okay, thank you. Thank you, Dr. Rizzi. Okay. So look here, the first question, entry and the possibility of the digastric. Students, we are informing that about the cadaveric image. Do you remember during our preparation, I told you the entry belly of the digastric? Sir, it is the derivative of the first pharyngeal arch. So it is supplied by the nerve of the first pharyngeal arch. Yes, the rule, Hilton law was applied. जो नदी जहाँ रहती है, जहाँ बहती है, वो सिर्फ सप्लाई करती है. While the possibility of the digastric, it was the derivative of our second pharyngeal arch. So the nerve supply of the second pharyngeal arch was the facial nerve. Okay, so the answer is our facial nerve and the mandibular. Now see, there is one twist. They ask in deep. I told you the trigeminal nerve and the facial nerve, they are important, but this time they ask little deep. They ask the mandibular nerve. It is having the different branches in which it gives one inferior alveolar nerve which gives nerve to mylohyoid. So this answer is right. Are you getting the point? Fine. So we already did this all the things with the proper 3-dimensional orientation. I had shown you the digastric muscle at the neck. Okay, so these things we had seen. Yes, cadaveric image was there. I'm searching for the cadaveric image. We had seen the 3-dimensional orientation, entry belly and the posterior belly, which are making fibrous band over our hyoid bone. Okay, so we talked about it. Okay, is it question is right? The image was not same. I'm searching for the correct image. Okay, ansa cervicalis was given in the option. Okay, so I'm writing the ansa cervicalis. Yes, beta, please can you inform me, Pooja? It was included with which one? Yes, Now, look here, sir, this is the one question, surgery question also you can say, the anatomy question also, the submandibular gland with duct resected. Now, see, during this procedure, which nerve admin? So this is the one repeated question. I taught you that this is suppose submandibular gland. So here is the our duct, okay? And I told you that this submandibular duct is having the close relation with the lingual nerve. So it is running in this way. So this nerve is initially laterally, then below, and then medially. So our formula was the LBM. Sir, this is our lingual nerve. This is the submandibular gland. But please help me. Please help me. This is our duct. Na? This is our submandibular duct. Also, you can say the Wharton's duct. Okay. So this is the relation lateral, below, and then medial. So here they ask the question. Yes, here this image, sir, this is the our gland, this is the duct, and the nerve is hooking down and then going medial side. Okay, so what you have to remember, sir, here the answer is the our lingual nerve, but students are saying the lingual nerve was not given. Now see, if lingual nerve is not given, then what you will mark? Lingual nerve is the branch of the trigeminal nerve. So you can mark the trigeminal nerve. Can you tell me the same kind of the option over here there? Because they're asking the duct, that's why. Okay, yes. Few students are saying, sir, facial nerve was not there, facial artery was there. If artery is there and they are not asking about the nerve, if they are not asking about the nerve, then you can go for the facial artery also. Okay, fine. Now, one more twist. Sir, trigeminal nerve is not the answer. If they are not given the lingual nerve, then you can go for the hypoglossal nerve also. So this is totally recall based. Please inform me what were the exact option. Marginal mandibular nerve. If they are asking about the duct, then don't mark the marginal mandibular nerve. Facial artery was in the option. Yes, Harini Priya is saying artery was in the option. So can I erase this facial nerve? If the facial artery was there, then go for the facial artery. Agree? Okay, so if the facial artery is given, then go for the facial artery. And if lingual nerve was given, then go for the lingual nerve. Okay, fine. Okay, sir. So now look for the next. All artery, no nerve. Okay, but students during the recall, they told me about the nerve. So you are saying about the artery. You are saying about the artery, no? Okay. Please inform me about the options, okay? So that I can create the correct one, okay? I will do. Now, which nerve doesn't pass through the marked foramen? So this is the one very easy question. Here is the foramina magna. The foramen asked, that was our, yes, jugular foramen. During the class, I taught you, this is a jugular foramen, which is having the anterior eye, posterior eye, and in between 9, 10, 11. Do you remember? Aage eye, piche eye, beech mein 9, 10, 11. Sir, the anterior eye was the our inferior petrosal sinus. Posterior eye is the our internal jugular vein. Also, you can say the sigmoid sinus, and in between there is a 9, 10, and 11 cranial nerve. So definitely the answer is the our 12th nerve. 12th nerve was not the content. Okay, duct was given or not? Yes. Now see, Dr. Aditya is saying trigeminal, facial, and the hypoglossal nerve were option. And few students are saying, sir, nerve was not given, but artery is given. Okay. So please inform me. Please inform me what is the correct. Yes, hypoglossal nerve. If hypoglossal nerve is there, yes, lingual nerve is not given, then you can go for the hypoglossal nerve also. Okay. Now the Sakshita is saying facial artery. It may be that there are the two options. Now, this is our favorite question, favorite topic. Yes, this topic from our viral video. Do you remember? Yes, gusse begwe gua ba gussa. During our NEET PG class, we did this one, gusse begwe gua ba gussa. So they asked the 10th cranial nerve. 10th cranial nerve is not containing. So just to see, 10th cranial nerve is having the special visceral efferent. The 10th cranial nerve is having the dorsal nucleus vagus. This GVE also. Sir, 10th cranial nerve. The 10th cranial nerve is having the gua and the ba both.
Sir, you are on mute.
Oh, hello everybody.
Yes, no.
Yeah, thank you. So this question had been asked. Yes, the 10th cranial nerve. The 10th cranial nerve.
Sir, again mute.
Yes. Hello everybody. Hope all the things are okay.
Yes, sir.
Yeah, thank you. So I'm not getting the correct idea about this one. I think this injury to the right anterior horn of the level of the cervical spine, this question, and history of the aphasia. So this question was already talked by the sir in the medicine. Okay, so I'm not looking for this. Yes, this question. Can you see? Patient visited the pain in shoulder after hyperextension exercise. So hyperextension means it is using the triceps. So longer the triceps. Just remember the longer the triceps, it is taking origin from the infragnular tubercle. So infragnular tubercle is the answer. Yes, it is getting avulse. Now come to the next question. A patient had pain along the lateral side of the thigh. So this was our simple, the meralgia paresthesia. Meralgia paresthesia. Okay. So if this is the meralgia paresthesia, so what is the root value of this nerve? Sir, the nerve is the lateral cutaneous nerve of the thigh, and this lateral cutaneous nerve of the thigh, it is coming from our ESL2 and the L3. So they given the option like the A, B, C, I think D, something like that. Okay, so definitely any kind of the pattern they are asking, the answer will be the L2, L3. Agree? Yes. GSA was given. If the GSA was also given, then it is not the answer, no? Because GSA, yes, remember, GSA trigeminal nerve and the few fibers of the vagus, they are coming from the GSA. No? So GSA is also not the answer. No? Fine. Okay. Yeah. Now look for the next. A patient visited to the clinic with injury due to excessive eversion of the foot. Now see, if there is the eversion, okay, lateral body of the foot is getting elevated, then medial side, there is the rupture of the tendon. Are you getting the point? Which ligament is on the medial side? Sir, deltoid ligament is on the medial side of the leg. Okay. Now look for the next. This was the very simple question. Sir, this is our urothelium. So answer is our ureter. Okay. Now the next question, which aorta? Again, this is the simple repeated question. They ask the patent ductus arteriosus. They ask the ligamentum arteriosum. So it deals from the our left sixth pharyngeal arch artery. Okay. Yes. So this all the things. Thank you very much. If any correction, please inform me at the discussion session at the channel. Okay. Thank you, everybody. Complete. Sir, next. Sir.
Anji, may you next?
Yeah.
I hope my voice is coming. Good evening and regards. My name is Dr. Anand and we'll start. Is my voice coming? Thank you. Hello. Yeah, is my voice coming? Hello. Hello. Yeah. Hi. Is my voice coming? Yeah. Hi. Good evening. Is my voice coming to everyone?
Yes, sir.
Yeah. Hi. Good evening. My name is Dr. Anand, and today we'll just discuss the questions. And we have the most important question. Number one, they had an image of congenital diaphragmatic hernia, and the question was there from there. Number one. Number two, very importantly, they had asked regarding if the mother is HIV positive, then what is the approach to the baby? If the mother is HIV positive, then we have to give this nevirapine and zidovudine for 12 weeks. Third question they had asked regarding the patent ductus arteriosus, which Dr. Shrikant has covered. And so these were the important questions from the pediatrics. Thank you so much. And last but not the least, they had asked regarding if the mother is HIV positive, how do you approach? And the two more important questions regarding the what you call drug of choice of the febrile seizure, that was rectal diazepam and intranasal midazolam. So anyhow, we're gonna have the what you called proper videos regarding this, and that's it regarding feeds. Thank you so much. Mike to the next person. Thank you.
Hello, dear friends. Am I audible and visible? Mukta
Yes.
ma'am? Yes, Ofta. So we are here with ophthalmology. That was a rapid recall, quite a rapid recall by Dr. Anand sir. चलो कुछ ज्यादा ही तेज था वो, है ना? ठीक है, let us discuss this. So this was a question which is, which disease do you see this in? है ना? Which was the disease? Hi everybody. Very good. ये तो इतना easy था. We have done this target sign. है ना? Pseudo exfoliation syndrome, pseudo exfoliation glaucoma. ठीक है, करेक्ट था ये. एब्सोल्युटली नो डाउट्स अबाउट दिस. Pseudo, yes. Good. ठीक है. Next question was this. What is this procedure used for? ठीक है. This was intact ring. We have done this intact ring, PMMA ring, semicircular ring. ये था बिल्कुल, है ना? This was keratoconus. This was a question number 2, है ना? Question number 2 था ये. Great. ये भी easy था, कोई डिफिकल्टी नहीं इसके अंदर. No problems in this. हाँ. पीडियाट्रिक्स फास्ट. अब ठीक है, थोड़ा स्लो हो जाते हैं, आ जाओ. हाँ, केराटोकोनस. ठीक है, अच्छा कह रहे फास्ट फास्ट फास्ट. डॉक्टर आनंद तरह की फास्ट. बुल्लस केराटोपैथी, कॉर्नियल गट्टे, सफरिंग फ्रॉम दिस. Most likely diagnosis, we had done this. This was Fuchs endothelial dystrophy, where endothelial cell loss is there. है ना? ये भी इजी सिंपल क्वेश्चन था. नो डाउट अबाउट दिस ऑल्सो. आ जाओ. अर्शदीप कह रहा फास्ट और फास्ट. अर्शदीप सिंह सिर्फ एक उस पर अटका फास्ट. ठीक है. Components of binocular single vision. We have done this also. Very simple question. Option B not there. चलो ठीक है. Option B not there. ठीक है. I'll search for the other option. ठीक है. You send me that option. If whatever option was there, please send me on this. Please send me on this number. ठीक है. WhatsApp it to me. ठीक है. Thank you. GSA was in the option. GSA, giant cell arteritis है. GSA क्या है? What is GSA? ठीक है, चलो. ये था साइमल्टेनियस मैकुलर परसेप्शन एंड फ्यूजन, है ना? दिस वी हैव डन दिस. ठीक है. दिस वाज अगेन अ वेरी सिंपल क्वेश्चन. ट्रकोमा. अच्छा, दैट वाज अ ट्रकोमा. ठीक है, चलो. ट्रकोमा नोट करके रख लेते हैं. देयर वाज ट्रकोमा. ठीक है. नेक्स्ट वाज दिस. विच स्टेटमेंट इज ट्रू अबाउट ऑर्बिटल सेलाइटिस? ठीक है. प्रोप्टोसिस यस होता है, रेडनेस होता है. प्यूपिल रिएक्ट्स नॉर्मली नो. And occluments are normal? No, occluments are definitely affected. ठीक है, तो this was the wrong option. Advanced center is most common. Yes, this was the correct option. Anterior septum, no. Treatment or antibiotics, no. It is with IV antibiotics. Intravenous antibiotics, that is there. ठीक है. Now lies posterior to. Lies posterior to. It was dog and house. ठीक है. यहाँ पे parrot है. Whatever some animal. How does it make a difference whether it was a dog or a parrot? ठीक है, चलें आगे. Next, this was a new question which was there. This was the question which was there. ठीक है. Painless progressive swelling at the outer canthus of the orbit. This is a dermoid cyst. ठीक है. This is a dermoid cyst which is there. Okay. Correct. This was the only question which was a bit new. ठीक है. And I think with this we come to the end of the one question which was shared to me by one student, but it has not been confirmed by other students, is drowsiness and altered orientation. Child brought to OPD. Which of the following drug may be responsible? It is brimonidine, but I don't think this question was there. This question was given to me by one student. Very confident that this question is there, but I don't think this question was there. ठीक है. Rest we are done. I'll hand over next, Mukta ma'am, to Dr. Praneeth sir.
Yeah. Good evening, sir.
Good evening. Good evening, sir. Over to you. I'm stopping my sharing.
Yeah. Thank you, sir.
Okay.
Yes, audio visual fine. So hope your exam went well, dear students. And so this will be a quick recall from ENT side. I won't take much of your time. Nearly 10 questions were there from ENT, I think. Okay. So see, this was the straightforward questions. Most of them were straightforward. Little bit tricky. 2 or 3 questions were there. So there was a patient who was presenting with epistaxis, known hypertensive and diabetic as well. I think the packing, anterior and posterior nasal packing, was unsuccessful. The next step you go for is ligation, and that you will go for sphenopalatine artery, which is the artery of epistaxis. So the name of the procedure is TESPAL, transnasal endoscopic sphenopalatine artery ligation. So sphenopalatine artery you will be ligating first if the ligation techniques were okay. And this is the question. 2-year-old came to emergency department with complaint of choking due to peanut ingestion. See, usually we do 5 back slaps to remove the laryngeal foreign body in a young patient, okay, in a very small age children, less than 5-year-old. Because you don't want to give unnecessary abdominal thrust and damage the rib cage, which is not perfectly developed. And intubation will further push the foreign body down, so you don't want to do that. Definitely. The question comes whether what is the best option among the A and the D, 5 back slaps or chest compressions. The child is unresponsive. So here maintaining the circulation is very important, right? So I feel chest compressions should be given first, I think, right? Okay, fine. If unresponsive was not there, then definitely 5 back slaps is the answer, right? So that's up to you. So there is a displaced nasal bone fracture after a road traffic accident. So for nasal bone fracture, what you will use? You will use Walsham forceps. For septal reduction, you will use Ash forceps, right? Okay. And a 20-year-old complaints of recurrent epistaxis. So adolescent male recurrent epistaxis. So DNA showing a red mass. Imaging shows a tumor in the nasopharynx extending into the nasal cavity. It is nothing but your juvenile nasopharyngeal angiofibroma, right? Okay. Right. Okay. I'm going fast only. Okay. A construction worker came in emergency due to fall from building, unstable vitals, upper airway injured with stones. So doctor did a procedure. Cricothyroidotomy is being shown in the picture, I think, and so this should be followed by a permanent airway procedure. I mean, for a better airway procedure. So immediately, if the tracheostomy is not available to provide the airway, you can temporarily go for this cricothyroidotomy, but as early as possible, it should be followed by tracheostomy to stabilize the airway, right? So tracheostomy should be followed later, definitely, right? A young male with occupational loud sound exposure. See, Rini was negative. See, this is right, left, Rini and Weber. So Rini was negative on left and positive on right, and Weber lateralizing towards the left side. So clearly this shows a pattern of left conductive hearing loss. No doubt about that, even though he is having occupational loud sound exposure may be there, but the tuning fork tests are clearly showing it as a conductive hearing loss. Well, left side conductive hearing loss very clearly the tuning fork tests are showing. So no confusions here, it's left conductive loss. 50-year-old diagnosed with CP angle tumor, Verroque bodies, Antony A and B patterns. So you have that is your vestibular schwannoma, right? Acoustic neuroma. 25-year-old presented with ear discharge episodes, hardness of hearing. See, a large central perforation, subtotal perforation is seen. See, myringoplasty can be done here. A modified radical mastoidectomy, see here, either inside ossicular erosions and your mastoiditis, a little bit of damage should be there, but it is not mentioned in the question. A simple, clear middle ear appears very much normal. Only tympanic membrane perforation is there. So you can go for a meringoplasty or tympanoplasty. Exploratory tympanotomy is not an option here. What's the purpose in just exploring the middle ear? Already you are exploring, you are seeing the middle ear through the perforation. So no need for exploratory tympanotomy. You need to close the perforation as a permanent procedure, right? Permanent. So tympanoplasty. If not given, myringoplasty is the best option here. Atticotomy is done for atticoantral disease, not for the safe type of disease, isn't it? This is a safe type of disease, isn't it? So that's the answer. The identify the PTA type. See, this is denoted in blue color. So if it is denoted in blue color, what does that mean? So blue indicates a left ear, right? So left. And there is a gap in between, isn't it? There is a huge airborne gap is there. So this is again conductive. Left conductive hearing loss is the answer here. Identify the marked structure. This is the barium swallow image. See, whenever the barium swallow is taken, anterior to the epiglottis, vallicula are there. The black arrow is showing you the black arrow is pointing towards the valliculae, where the barium deposits will occur. A little bit of barium will accumulate there. And on either side, in the both the down below, where the white arrow is showing, there the pyriform fossa will be there. Pyriform fossa will be there. There some barium will be accumulating. So those are the areas being shown here. In fact, even I have thought it could be ossification, but not. No, this is a barium swallow image. This is the vallicula area, and this is the pyriform. In the fossas, there the barium will get accumulating. So the answer, the white arrow here is showing you the pyriform fossa. So these are the questions from ENT. 2 to 3 tough questions were there, the foreign body and the barium swallow. But apart from that, you are tuning folk test, conductive hearing loss, audiometries, and all those questions, JNA, epistats, all are very regular, normal questions, straightforward. So, so all the best, and hopefully you might have marked all the correct, right? So with this, I end the ENT discussion. Any other doubts? Any doubts, you can just personally message me, right? Thank you. So I can transfer it to the next one.
Hello, good evening, sir.
Sir. Yeah.
Very
Okay,
good
I'm
evening.
closing, sir.
Okay, thank you so much, sir.
Yeah.
So, dear students, I am just sharing my screen. Just give me a second. So, I hope all of you had a great day, very tiring day, but still a memorable day, because all your hard work finally has been fruitful with this examination. Hopefully, you are going to do great. You have done great. Hello, dear students. Chalo. So this is a NBE pattern MCQs, like Dilip sir told. So we are going to discuss almost 8 questions came, and you can see that the infections topic has been the favorite of the examiner, we can say. If you are having any more doubts or any other options or images, please you can message me on WhatsApp through this number. And my analysis is NEET is now the new INI-CET. Okay. Yes. Chalo. We are going to go fast. So I will just show you the buzzwords and the answer. So there are multiple fluid filled lesions around the lips, and there is a Zang smear which is showing the multinucleated germ cells. Basically, this is a recent FMGE question also. So it is HSV, herpes simplex viral infection. I hope all of you have marked this correct. If you are having any different option or any different thing in the question, you can please put your points in the comment section. I will be checking them. Okay, right. Chalo. Next is this question. So there is a farmer who is having irregular swelling of the foot, and there are sinuses, and there are black granules. So this is GST. I hope you remember RGV story which we have discussed while discussing the mycetoma, and specifically the granules are black in color. So it is eumycetoma which the examiner is talking about. So what will be the answer? It is going to be the septate hyphae, which are 4 to 5 micrometers in width. So I hope this is what is the question which was given. So this is there in the notes also, right? Next is this question. So indurated plaque with central atrophy and chest x-ray is revealing apical calcification. So basically it is pointing towards a diagnosis of tuberculosis, and if you are given that there is a lesion which is having central atrophy, so this is the indurated block with central atrophy, so points towards a diagnosis of lupus vulgaris, which is a cutaneous tuberculosis. So to confirm the lupus vulgaris and the diagnosis of tuberculosis, what we can do, actually skin biopsy is the best one, but it is not given in the options. Okay, so what we can say is the better answer, it is PCR. Polymerase chain reaction is going to be the better option. If biopsy is not mentioned, can you please tell if the biopsy was mentioned, yes or no? Dear students, all of you. Was biopsy mentioned in the options, yes or no? Slit skin smear is going to be used for leprosy, and probe test, it is used for sinuses, and Mantoux test is used in tuberculosis, but it is not going to be confirmatory. Okay, thank you so much for confirmation. Chalo, and this is the taken from the Rooks. You can see the TS PCR has been successfully used to confirm the diagnosis of lupus vulgaris. Chalo, fine, great. Next, this is a question, we can say it is a previous PYQ only. Papillovesicular pruritic rash is there, gluten sensitive enteropathy. So this might have been already discussed in pathology also. So granular IgA deposition, all these are pointing towards a diagnosis of the dermatitis herpetiformis. Very clear cut question. Yeah, this is the next one. So reticulated oral mucosal lesion is there, and there is burning sensation on spicy food intake. White lacy plaques which are pointing towards a Wickham striae are present. So what is that medication which we need to think of, which is most likely responsible? So it is beta blockers. So remember, dear students, beta blockers. So these are the drugs implicated in the drug induced lichen planus, and here you can see in the antihypertensive, whatever is bold is the most important one, and here you can see labetalol, propranolol, and here even lithium is there if you observe carefully, but this is not so common when compared to the antihypertensive medications. So this is a very chronically repeated question. So non-itchy lesions over the elbows, extensor surfaces, they are basically hyperkeratotic and hyperpigmented. This was what mentioned. And what is the most appropriate next step? So what is the diagnosis which you want to think of? It is phrenoderma toad skin. So in such cases, vitamin A deficiency is very important. So what we can do is ophthalmologic examination. Ophthalmologic examination is what we are going to perform. Yes. Okay. Chalo. This is the next question which some students are having a query regarding. Stable hypopigmented patch is present since birth. So this is very important point. Since birth, and there is no change in size or color. So, and hypopigmented but not depigmented, this was also mentioned. And wood slump is showing dull white accentuation. Diascopy is negative. So with this first clue that it is there since birth, we can rule out the vitiligo and also indeterminate leprosy because they are not going to present since birth. And nevus depigmentosus anemicus both can be present by birth, but remember, dear students, diascopy is going to be having a finding in nevus anemicus, where we are going to see that the borders are going to join and the skin is going to be look alike. That is, diascopy is going to be positive. So answer here is going to be what is left out, nevus depigmentosus. And here you can see clearly, I have told you this, diascopy is going to be positive in nevus anemicus, whereas it is going to be negative in the nevus depigmentosus. And also wood slump finding is going to show dull white accentuation in nevus depigmentosus, which was mentioned in the question. So I hope this was the same question which you have recollected. Right. Okay. Thank you so much. Chalo. This is the next question. So freckling, sun exposed areas is present, and biopsy is confirming basal cell carcinoma. BCCs are present, and there is a which are the following DNA repair pathway. So I hope all of you know this diagnosis. It is xeroderma pigmentosum, and remember, dear students, it is due to the nucleotide excision repair pathway defect, which we are going to see the xeroderma pigmentosum. So I hope you have enjoyed this particular recall session. Just relax after this session, watch some movies, they are there in the theaters, or if you are liking pilgrimage, you can visit any of these places and pray to the god that you are going to do great in the exam, in the results. And if you have any queries, if there is anything which you want to mention regarding the question or options or images, you can reach me out on this WhatsApp number. Okay, thank you so much, dear students. I would like to conclude my session and pass on to the next faculty. Yes, who is available? Shubhamji, could you please
Dr. Atul sir is coming, sir.
Okay. So till then, any students, any other thing which you want to tell me? So you can happily enjoy the, after today, don't try to again go back to the recalls and all. Just relax, chill out. Okay, there are so many movies. Oh, a very good evening, Atul sir.
Thank you, Dr. Srinivas.
Okay, please
Am I
take it.
audible?
Yes, sir, you are audible, sir.
Okay, so I will not take much time. We'll finish it fast. Okay. So total 9 questions. 9 questions, out of which one I found was out of box. So let's discuss those fast. I know you are tired. First question was simple. There were multiple neck injuries with multiple penny bruises, one bruise on one side and 3 bruises on other side. This clearly makes the answer as throttling. Okay, so it is, some people got it confused with mugging. No, it's not mugging. In mugging there is no localized injury. It is only the localized injury means throttling. Okay, then garlicky odor was there. Some people got confused between arsenic and aluminum phosphide, but here it was colorless stools. Initially, blood tints diarrhea. Colorless stool means cholera like diarrhea. So the answer was clearly arsenic. Am I audible or not? Am I audible or not? Okay. In the next question, the patient had consensual sex, but the age of the girl was only 16 years. So below 18 years, it is always rape and always to be reported to police. Okay, so here the answer will be B. The girl's consent is not valid. Clear? Next question, the person was having some kind of delusions. So of course, you need to do a psychiatric evaluation. Only then after that you can decide how serious it was, the injury was. So the answer will become proceed. The most important here will be refer for a comprehensive psychiatric evaluation. Okay. Then throttling option nahi tha, so what all were the option? What were the options? Throttling was not the option. What were the options? Barking was there. What else? Throttling was there in the option or not? I didn't need to know the other answers. Fracture of thyroid cartilage is okay, but barking was, throttling was there or not? Yes, it was there. Then the answer is throttling. फिर क्यों बोल रहे हो throttling नहीं था? ये भी याद नहीं है. ठीक है? So wrote typical findings of pulmonary thromboembolism. After 2 days, it has occurred. So here the answer is fat embolism. Air embolism occurs immediately. Air embolism occurs immediately. If throttling was there, the answer is throttling. बात खत्म. ठीक है? I know you are tired. Otherwise, I would explain. कितनी बार तो समझाया. Barking हो या कुछ भी हो, whether barking was there or not, if there are no localized neck injuries, means the answer is throttling. Simple. Okay, here the person survived for 5 days. So after 3 days, typically what happens is that the lipolysis occurs. Lipolysis leads to ketogenesis. Ketogenesis leads to ketone use by brain. So this whole thing, when the ketone bodies are used, that is called ketosis. So here answer will be ketosis. Some people got it confused by lipolysis, but lipolysis is only the first step. The answer will be ketosis. Okay. Next question, toxic fumes from the factory. So what will you do? Common sense question. You will close all your home so that the fumes do not come into your home. Very simple. So it is a fumes coming from a factory. So you close your home. So the answer here will be close all windows and cracks in home. Clear? POXO Act is applicable to anybody below 18 years, whether boy or girl. Okay, so the answer here will be D. Next question. This was out of the box. Here basically what we do is in the quadriceps muscle,
quadriceps muscle. When we give a stimulation, it contracts. It contracts, because of which patella moves. Patella moves. And this is positive till 1 to 2 hours after death. Okay. So even if this question you may not be knowing about this term, don't worry, nobody knew about it, but you could have easily ruled out from the other choices. The answer is A. Okay. Then, so this we have done, the Jesco's phenomena we have, so that we have done all. Thank you very much. And you can please reach out to me in case some correction is required in the questions. I know you are all tired to the core. Maje karo, chalo. Bye. And who is the next faculty? Hi, Dr. Ankul. Welcome, please.
Good evening, sir.
Thank you.
Thank you, sir. Good evening, friends. Am I audible? Visible? Yes, we start. First question. Yes, most of the student did not read the complete option. They just saw orange color tonsil. I told you, yes, tonsils are orange color. Yes, if you drink Tang, most common flavor of Tang is orange. Your tonsil would become orange color tonsil. Yes, now it is number one drink, A1 drink. Yes, that is ABC-A1. ABC-A1 gene defect. In this ABC-A1, take cholesterol from periphery to HDL. If this is defective, then HDL will not be synthesized. Decrease HDL, decrease HDL. Yes. And there would be deposition of cholesterol in tonsil, peripheral neuropathy, organomegaly would be there. So answer is Tangier disease. Yes. Question: which amino acid is not synthesized, will not be synthesized due to B12 deficiency in a patient with history of ileectomy? Point it out. Every exam is important for those who are going to appear. Yes, students, that this question was asked in this. Yes, previously, that ileectomy, this B12 is absorbed in ileum. Ileectomy, history of surgery on ileum may lead to B12 deficiency, elevated homocysteine level. We all know that homocysteine can be converted to methionine by homocysteine methyltransferase. Homocysteine methyltransferase, and the cofactor is vitamin B9 and B12. In both of these cases, if these are deficient, that will lead to homocysteinuria. Methionine will not be synthesized. Bengaloblastic anemia would be there, homocystinuria will be there, but in B12 deficiency, there is methylmalonyl aciduria, as methylmalonyl coenzyme is committed to succinyl coenzyme with the help of vitamin B12 if this is deficient. So in this question, they have given all the hints: homocysteine level, increased methylmalonyl, peripheral neuropathy, ileectomy, which will not be synthesized. Answer: methionine. Now we found that in the same question, if they say B6 deficiency, then answer would change to cysteine. You all know that homocysteine is converted to methionine. Sorry, methionine से बात कर लेते हैं. Normally what happens, methionine is converted to homocysteine. This homocysteine bind with cyan to form cystathionine. By cystathionine, beta synthase, and the cofactor for this is vitamin B6. And if B6 is not there, then this reaction would not occur and cysteine will not be synthesized. Previously, this question was asked in our NEET PG. Okay. So in this question, answer is methionine. Yes. Next. Patient had markedly elevated plasma phenylalanine level, low tyrosine level. You all know phenylalanine is going to tyrosine by phenylalanine hydroxylase. In this reaction, tetrahydrobiopterin is going to dihydrobiopterin. Dihydrobiopterin is converted back to tetrahydrobiopterin by dihydrobiopterin reductase. If phenylalanine hydroxylase is deficient, this is classical type of phenylketonuria. But in this question, they have given that phenylalanine hydroxylase is normal. Yes, normal. So there may be defect in dihydrobiopterin reductase, but dihydrobiopterin reductase is not given the option. They have given option biopterin. So answer would be biopterin. Yes. Okay, dear. Fast kar lete hain. In this question, they have LDL is high, triglyceride level was normal, increased cholesterol, xanthoma, family history. Yes, type 2A. Hyperlipoproteinemia. In type 2A hyperlipoproteinemia, LDL receptor is defective or ApoB100 is defective. If this is defective, LDL will increase, cholesterol will increase, triglyceride will be normal, cholesterol increase, coronary artery disease, chest pain, myocardial infarction, family history would be there. Yes, answer is C. Okay. Yes. In this question, patient presented fatigue, gum bleeding, multiple follicular hemorrhage on lower limb, bleeding tendency. These findings are most concerned with deficiency of which enzyme activity? Vitamin C deficiency, scurvy. They have given the clinical picture, and we know vitamin C as C, water, hydroxylation of proline and lysine. I told you proline is going to hydroxyproline by prolyl hydroxylase. Lysine is going to hydroxylysine by lysyl hydroxylase. पी ले यस सारा समुद्र मेरे पास है एक बूंद पानी मेरे पास है पी ले तो प्रोलिल हाइड्रोक्सीलेज लाइसिल ऑक्सीडेज copper is cofactor for this. Okay, next question. In this they have given iduronidase deficiency. Iduronidase deficiency is there. This is Hurler disease. In Hurler disease there is deposition of heparin sulfate and dermatan sulfate. Okay. Okay, dear. In non-alcoholic hypertensive patient on hydrochlorothiazide therapy, diuretic, chronic use of diuretic lead to vitamin B1 deficiency. Yes. So this is point indicating that thiamine deficiency may be there. Cerebellar ataxia, peripheral neuropathy, symmetric tingling sensation, cardiac failure, pedal edema. This is typical picture, dry beriberi, symmetric motor and sensory neuropathy, high output cardiac failure. Yes, this is wet beriberi. Wernicke's encephalopathy or ataxia may be there due to thiamine deficiency. So answer is thiamine. We can rule out B12 because in B12 heart would not be affected. Okay. Yes. Beta edema would not be there. So answer is thiamine. Next question. A child present with multiple freckles, severe photosensitivity, early onset skin cancer. Yes, this is, I told you nucleotide excision repair. This is repeat question for NEET PG 24. Skin rash, blister on sun exposed area. That is xeroderma pigmentosa. In xeroderma pigmentosa, nucleotide excision repair defect. Okay. Yes. So you all know that try 0 calorie Coke, 3 nucleotide excision repair. Okay. Now, so answer is nucleotide excision repair, xeroderma pigmentosa diagnosis. A minor stuck in tunnel for last 5 days, not taking food, मतलब 5 दिन से खाना नहीं खाया, तो what will be there? Brain will utilize glucose, and in starvation it utilize ketone bodies. So it will depend on ketone bodies, ketoacidosis. Yes. Yes. Up to 16 to 18 hours glycogenolysis, up to 48 hours, gluconeogenesis and beta oxidation of fatty acid. After 48 hours, then this gluconeogenesis, the substrate decreases. So that's why brain, heart and skeletal muscle, most vital organ, utilize ketone body in starvation. So 5 days, answer would be ketosis. Clear? Hexosaminidase deficiency, seizure, cherry-red spot with no hepatosplenomegaly, means this is Tay-Sachs disease. TSH, mnemonic was TSH, Tay-Sachs disease. Hexosaminidase is deficient. T4 Tay-Sachs, T4 2. S4 Sandroff, S4 second. So this is GM2 gangliosidosis. In this chariot spot would be there, neurological symptoms would be there, but no hepatosplenomegaly. Okay, so this is GM2 ganglioside accumulation. Yes. Now, this is ADDA. I told you CID, SCID, ADDA, adenosine deaminase. Yes, severe combined immunodeficiency. ADDA will be deficient. Okay. Now this is frame shift mutation. Yes, you know, if number of bases added or removed in multiple of 3, then there is no frame shift mutation. Note multiple of 3. Just like in this question, they have inserted a new nucleotide at the initial part of messenger RNA. This is long messenger RNA having 900 nucleotide. At 4th position, you have inserted. So all the frame would be shifted. The complete frame would be shifted. So complete change in the protein production would be there. Answer is C. Yes, answer is C. In this, GM2 ganglioside was the answer. Okay. Yes. If you have any change, any question, you can message me 8851 397 Best of luck for your result. Yes. कौन सा डिटेल में बताना है बच्चों? ये लास्ट क्लास है, इसके बाद तुम जा सकते हो. Yes, I think. Let me check. Yes, if I'm yes, अपना कंप्लीट हो गया है. सो अब एंजॉय करना, चिल करना और रिजल्ट पे पार्टी करेंगे. ओके डियर. ओके, बेस्ट विशेस.